Good morning, everybody. We are ready to start our second day in the symposium, and we'll start with the first session will be pathology. Sarah is our first speaker. Can you share your screen, Sarah? Can you please keep your mics closed? I think this one is Ahmed. Riham, can I ask you to help because Sarah is getting kicked out of Zoom.
يا دكتور هي المفروض عايزة تعمل شير بس ما قادرة ولا شو بالضبط؟
قالت كل مرة she's getting locked out of Zoom. هي كانت بدت شيرنج طلعت لأنه she gets kicked out of Zoom. أنا كان عندي نفس المشكلة امبارح. كم واحد كان عنده نفس المشكلة. Whom do we approach بالتكنيكال
أنت عارفة
problem؟
دكتورة نادية؟
Yes.
أنا بكون موجودة، بكون سامعاكم، بفتح الزوم بيختفي الباوربوينت، بفتح الباوربوينت بيختفي الزوم. صراحة أنا ما فاهمة، فحجرب أعمل ريستارت لللابتوب وأدخل تاني. أوكي؟
Okay.
طيب ممكن
We'll wait a few minutes, otherwise we can take the second speaker.
أوكي. أوكي.
To solve the problem.
أوكي I'm back. والشير السكرين واضح صح؟
Yes, the share is clear.
Okay.
And make sure that it moves. Just move one slide so that you make sure that it moves. Yes, it's moving. Perfect. Go back. So let me introduce you and start the session. Welcome, everybody. Sarah, are you ready? Is everything okay?
Yeah, everything is okay.
Tamam. Let me start the session, introduce you, and then you can start your. Assalamu alaikum, everybody. Welcome back to the second day in the fourth multidisciplinary team symposium for October 2025. And the topic is early breast cancer. Today we start with the pathology session. We have multiple speakers, and I hope we will have a lot of discussion, especially we're inviting discussion from surgeons and oncologists, and of course, our hosts, the radiologists. We are starting with a young pathologist who was one of my brilliant students. She just finished her degree, but she has been very active. She is working for Rabat Hospital University, and she has already published researches. I sensed it when I supervised her that she has a deep interest and knowledge in research. She will be the first talk in our pathology session. Her talk is about understanding DCIS from the perspective of pathologists, histopathologists, and you are welcome to ask her all the questions that you need to ask. We will organize this so that we can go through all our speakers. اتفضلي سارة.
Okay, thank you, Dr. Nadia. So, to understand the pathological features of DCIS and carcinoma in situ, we will first start with the normal structure of the breast. So, anatomically, the breast is composed of lobules and ducts. So, the lobules is where the secretion of milk happens, and this milk is transported to the nipple through the ducts. So, we have over here, we would have the peripherally located ducts, and in this area we will have the lactiferous ducts. We would call this structure the terminal ductal lobular unit. Under the microscope, the terminal ductal lobular unit will look like this. The epithelial structures are composed of the lobules and the ducts. These are the lobules, and big structures like this are the ducts of the breast. According to what stage the female is in her reproductive years, and whether she is lactating or not, we would expect to have more epithelial cells if she is lactating, or if she is premenopausal, it would be more fibrous. We will have more background of connective tissue if she is more postmenopausal. If we looked at a higher power, at the lobules or the duct, we would find that they are double layered. So we would have the inner cuboidal layer of cells, which what secretes the milk, and we would have an outer layer of myoepithelial cells, which is what squeezes the lobules and ducts to secrete the milk. In both lobules and ducts, we will have, in addition, at the outer part, a basement membrane, which we see here as a band of collagen tissue, which looks pink in color. So when we say that we have ductal carcinoma in situ, it is defined by the presence of neoplastic epithelial cells confined to the ductal lobular system. So this is a duct or lobule that is completely distended by neoplastic cells. However, if we look at the periphery, we'll find that we have an intact outer myoepithelial layer, and the basement membrane would be intact. The ductal carcinoma in situ is believed to originate in the terminal ductal lobular unit. However, it can extend into the larger ducts. It can reach the breast, the nipple of the breast, to form Paget disease as well. So ductal carcinoma in situ is clinically, radiologically, and histologically a heterogeneous, non-obligate precursor of invasive breast carcinoma. The grading of DCIS mainly depends on the nuclear features of DCIS. So we would say that we have low-grade ductal carcinoma in situ when the nucleus is small. It can be around 1 to 2 times the normal size of the nucleus of the normal ductal epithelium. We would see that all the nuclei have similar shape and size. Mitosis is not expected to be found in low-grade ductal carcinoma in situ, and necrosis is unusual as well. However, we can find microcalcifications because these low-grade ductal carcinoma in situ tend to have secretions in them, and these secretions over time tend to calcify. When we say that we have intermediate nuclear grade, we start noticing that the nucleus is getting larger in size, and there is more variability in the shape of the nucleus, so that they start looking different, have different sizes and shape. In intermediate grade, we can find necrosis. The necrosis can be punctate, meaning that it could be individual cells that are necrotic, and it could be comedo, and in this situation, we will have extensive necrosis. Microcalcifications are also present in intermediate grade ductal carcinoma in situ, which could be due to the secretions or to the necrosis. In high nuclear grade ductal carcinoma,
Sarah, just a second. Please, can you keep your mics closed? Dr. Safa, please close your mic. Thank you. Okay, Sarah, it's okay.
Okay. So in high-grade nuclear ductal carcinoma in situ, the nucleus starts to get more ugly. So it's getting very large in this situation, and they are pleomorphic, meaning that they are extremely different, look different from each other. The nuclear size can be as large as 2.5 times the normal nuclear size. We will have prominent nucleoli, and mitosis is frequent in high-grade ductal carcinoma in situ. Central comedonecrosis is often present in high-grade ductal carcinoma in situ. We usually say that we have comedonecrosis when the necrosis involves more than 50% of the ductal space. So what we have here that looks pink in color is necrosis inside the DCIS, and we have here remaining ductal carcinoma cells. The presence of necrosis is correlated with the finding of mammographic calcification because necrosis eventually turns into calcification. An inflammatory and fibrotic reaction can be sometimes present surrounding high-grade ductal carcinoma in situ. And in this situation, usually in ductal carcinoma in situ, it's not possible to see it or to feel it during grossing. However, when it's associated with inflammation or fibrosis, in this situation, it could be palpable in examination, and it could also be associated with gritty feeling. The grading system for ductal carcinoma in situ doesn't indicate progression, meaning that we don't usually expect that low-grade ductal carcinoma will progress with time to intermediate and high-grade ductal carcinoma in situ. In fact, each one of them is associated with different molecular and genetic profiles, and they have different progression rates to invasive breast carcinoma. So the subtypes of ductal carcinoma are according to the architecture of the DCIS. We would say that we have solid type DCIS when the terminal ductal lobular unit is completely filled with neoplastic cells. So in this situation, all of the space is filled with neoplastic cells. We would say that this is solid type. Solid type is usually of low-grade type. we would say that we have cribriform DCIS when it's filled with cells. However, we can find intervening circular spaces in between in the ductal lobular unit. A micropapillary DCIS, in this situation, we will have epithelial projections projecting from the wall, like these structures over here. Usually in the micropapillary type, it will have a bulbous or broad tip. Micropapillary DCIS is usually is more likely than other type to involve multiple quadrants of the breast. In papillary ductal carcinoma in situ, we as well have projections from the wall, like the micropapillary type, but the projections are larger in size, and inside these papillary structure, we will find a core of connective tissue and blood vessels. So the current standard of treatment, if DCIS is found in a core biopsy, is to conduct a breast-conserving surgery in addition to radiotherapy or not. If the ductal carcinoma in situ is multifocal and extensive in the breast, in this situation, it would be recommended to perform mastectomy. So when receiving an excision or resection specimen, it is important to assess for completeness of excision. So according to the American College of Pathologists, completeness of excision or a negative surgical margin is when we don't have a tumor at ink. So if this is the surgical margin of the specimen inked in black, we would say that we have a negative margin. If there at the margin we don't have any tumor or DCIS. But according to the WHO, the recommendation is to have DCIS or tumor cells at least 2 millimeters away from the margin. So we can see that in this biopsy, DCIS is positive, the ink is touching the DCIS, so we would say that this is a positive surgical margin and there is a need for re-excision to decrease the risk of recurrence. When it comes to biomarkers in DCIS, there is currently no universal agreement. However, studies and clinical trials have stated that receiving adjuvant hormonal treatment therapy in case of ER-positive DCIS reduces the risk of recurrence and of future risk of invasive breast cancer. So the natural history of DCIS, we don't have a complete, full understanding of the natural history yet. However, we know that in case of recurrences, around 50% of cases will be of DCIS and about 50% of cases will be of invasive breast carcinoma. We know that a high-grade tumor have a higher rate of progression to invasive breast carcinoma. So high-grade DCIS have an average progression in 5 years, but if it's a low-grade DCIS, the progression can happen in decades or years. So the factors that are associated with an increased risk of breast recurrence of DCIS include younger patient age, larger lesion size, a high-grade DCIS, when there is presence of comedonal necrosis, and when the margins are positive. So there are a lot of mimickers and pitfalls for the diagnosis of DCIS, but I have limited my differentials to the most common situations. So the differentials for DCIS could be benign cases like usual ductal hyperplasia and atypical ductal hyperplasia, or it could be malignancy like invasive and microinvasive breast cancer. So to determine if what we have is a usual ductal hyperplasia versus DCIS, first we will look at the morphology. So in usual ductal hyperplasia, we would expect that the cells will have
محاضرة.
there will be mild variability in the cell size and shape. So they will look a little bit different from each other because they are polymorphic, meaning that they have origin from different stem cells. However, in ductal carcinoma in situ, because they are monoclonal, we would, when we compare it to the usual ductal hyperplasia, we notice that they look almost exactly the same. Another feature that we can use to differentiate between the two entities is that in usual ductal hyperplasia, it have a streaming pattern, meaning like the nucleus have different, pointed into different directions. However, in ductal carcinoma in situ, it would have a polarization, meaning that if there are spaces in the ductal carcinoma in situ, the nuclei would be oriented around it. Also, when there are spaces in usual ductal hyperplasia, usually they look slit-like, meaning that the spaces are elongated and they are usually located at the periphery. However, in ductal carcinoma in situ, they are usually have of similar sizes and shapes, and we can have architectures like trabecular bars and Roman bridges. In difficult situations, sometimes only the morphology is not enough to differentiate between the two, so we would use immunohistochemical stains. So when we use cytokeratin CK5 and 6 in usual ductal hyperplasia, it will have a variability or what we call a mosaic pattern, meaning that there's different uptake among the cells. But here in DCIS, we notice that it is negative, which means that we don't have the brown staining of cytokeratin. When we use an ER stain, we will as well have a mosaic pattern in usual ductal hyperplasia with different uptake. So in areas it is extremely brown, and in areas it's almost negative. However, it is strongly and diffusely positive in DCIS. They are all brown in color. When we compare between atypical ductal hyperplasia versus ductal carcinoma in situ, atypical ductal hyperplasia usually have low-grade nuclear features, and it is focal, meaning that we wouldn't expect to find more than 2 ductal spaces involved with atypical ductal hyperplasia, and its size should be less than 2 millimeters. To differentiate in each case of ductal carcinoma in situ, it's important to look for microinvasion and invasive breast carcinoma. Microinvasion is defined as small or irregular clusters of cells invading the basement membrane that should be less than or equal to 1 millimeters. So if this is a ductal carcinoma in situ, over here we can find that there are individual cells that have escaped and they are present in the connective tissue. If ductal carcinoma in situ is surrounded by inflammation, sometimes it's difficult to assess for microinvasion. So in this situation, we can use immunostains like keratin. So to complete a histopathological report in ductal carcinoma in situ excisional biopsy, it is important first to state whether the process was a lumpectomy or a mastectomy. It is important to decide the laterality and the exact position of the tumor. It's important to note its histological type and its exact size. It's important to note its architectural pattern, its nuclear grade, whether necrosis was present or not, and whether microcalcifications were noted in the specimen, especially if it was noted in radiology. It's important to comment on the margin status, and if the specimen was a mastectomy, to comment on the lymph node status and pathological staging. So another type of carcinoma in situ is lobular carcinoma in situ. It has a different genetic mutation, which causes the cells to not be attached to each other anymore. So in lobular carcinoma, the main feature is that they are discohesive, meaning that the cells are disconnected from each other. To say that we have lobular carcinoma in situ in comparison to atypical lobular hyperplasia, more than 50% of the acini in the terminal ductal lobular unit should be filled, expanded by the neoplastic cells. Usually, lobular carcinoma in situ is not associated with microcalcification, and this is why it's usually diagnosed incidentally. We have two major subtypes of lobular carcinoma in situ, which is pleomorphic lobular carcinoma in situ. And in this situation, we will notice that the lobular carcinoma cells are different from each other in the size and the shape. In florid type lobular carcinoma in situ, this usually will have cells of similar shape and size to the classic lobular carcinoma in situ, but this type is marked by distension. There is marked distension of the terminal ductal lobular unit. So we would see that they are completely distended by the neoplastic cells to the point that there is almost no spaces between them. So this is the florid type. Pleomorphic lobular carcinoma in situ and florid type often demonstrate comedian necrosis and calcifications, so they are usually detected in screening mammography. About 87% of cases are associated with invasive breast cancer, so whenever we have pleomorphic or florid type lobular carcinoma in situ, it's very important to look at surrounding tissue and look carefully for invasive carcinoma.
Just a
The
second,
natural history.
Sarah, please,
Okay.
can you mute your phones so that we don't have background noise? Please mute your mics. Can you please mute your mics so that there is no background noise? Thank you. Mu'tasim as well. Thank you. Okay, Sarah.
So the natural history of classic lobular carcinoma in situ, it is usually both a risk factor and non-obligate precursor of invasive breast cancer. The rate of risk of subsequent breast cancer in classic type lobular carcinoma in situ is 8 to 10 times the risk in the general population. Classic lobular carcinoma in situ increases the risk of both ipsilateral and bilateral breast cancer, and it increases both for lobular and ductal carcinoma of the breast. The current management of lobular carcinoma in situ include surveillance and risk reduction strategies for both breasts. The American Society for Clinical Oncology recommends using anti-estrogen therapy as chemoprevention since most cases would be ER positive. Patients with incidental classic lobular carcinoma in situ on core biopsies have low upgrade rates in subsequent biopsies. Therefore, usually there are no guidelines for re-excision. The margins were involved in core biopsies, and also it is usually not necessary to assess or report on the margin status for the classic type. The upgrade rates are usually higher when the radiological, there is no, or it was not noted whether there is radiological and pathological correlation, or for cases where the core biopsy was for mass lesions. When it comes to information about the natural history of pleomorphic and florid type lobular carcinoma in situ, right now it's very limited. However, what we know is that around 25 to 60% of cases are upgraded to carcinoma and excision. Since we have different approaches for lobular carcinoma in situ and ductal carcinoma in situ, it's important to differentiate between the two. So in microscopy, like we said, in lobular carcinoma in situ, it would be discohesive cells, meaning that they are separate from each other. But in ductal carcinoma in situ, they will be cohesive. In lobular carcinoma in situ, sometimes we can find intracytoplasmic vacuoles or secretions, like we can see over here. In ductal carcinoma in situ, we notice, like we said, that there is polarization, meaning that if there are spaces like this in the duct, the nuclei would be oriented around it. We can use also immunostain to differentiate between the two. So in lobular carcinoma in situ, we would expect to find negative staining for E-cadherin and beta-catenin, but in ductal carcinomas in situ, it would be strongly membranous positive. So if these areas, which are blue in color and not taking the brown stain of immunohistochemistry, these areas would correspond to lobular carcinoma in situ. However, in normal areas of the breast and in ductal carcinoma in situ, we'd expect it to look like this, meaning that the staining would be at the cell membrane. So this concludes my presentation, and thank you for listening.
Thank you, Sarah. This was a wonderful presentation and opening for our pathology session. Thank you so much.
Thank you.
Our next speaker, if you unshare, Sarah, we can add Salwa. Sarah, can you unshare?
نظهر لي دكتورة نادية إنه يعني I stopped sharing.
Okay, thank you.
Okay.
Salwa, are you there? Yes. We can see your screen, Salwa. Yes, Salwa, good morning.
Good morning, yeah. Can you see?
Yes, we can see your screen, but can you put
But
it
I'm not
in...
seeing it, yeah. I'm not seeing it. I don't know why.
Close and unshare and share again.
Okay, okay. Close, share again.
Yeah, we can see it.
You are seeing it, yeah?
Yes.
But I'm not seeing my screen.
Okay, then unshare and share again.
Okay. Stop share. Seems there is a technical problem. I don't know what happened. Trying to share it again.
Yeah, it happened with Sarah, and Sarah was okay. You're sharing now.
Yeah. Now I'm seeing it.
Do
now.
you see your screen?
Yeah.
Okay, then just put it on presentation mode so that it fills the screen. Yes, that's beautiful.
Yeah, that's it.
Now, I think you are set, yes, and the sound is good. Let me just start the introduction. سلوى is بالعربي كافحنا مع بعض مش كده؟ Yeah, we have worked together in Sudan for a long time and tried to build up the pathology service in Sudan. She's a very industrious histopathologist, and if I read her qualifications and memberships, we'll take the whole lecture. So let me introduce her as a very active histopathologist, teaching pathology to undergraduates and postgraduates with shall I say, interest in gastroenterology, gastrointestinal and liver pathology. She is a former head of histopathology at STAC Laboratories, the national public national health laboratory in Khartoum, Sudan, and as well at Soba University Hospital. She's a very active member of the Sudanese Society of Pathology and is affiliated to An University, amongst so many other memberships. I will leave it at that, and her lecture will take you into what is new in histopathology. تفضلي يا سلوى.
Thank you for the nice introduction, Nadia, رفيقة الدرب. Thank you, everybody. I would like to thank the organizing committee for inviting me to deliver this talk. Good morning, everybody. We will talk about advances in pathological evaluation of invasive. Thank you for Dr. Sarah for introducing in situ carcinoma. We will go over evolution in the WHO classification of breast cancer, and then the morphological, the morphology and the molecular subtyping, and the predictive and prognostic markers, and what is new. But we will not cover the cytology or neoadjuvant assessment. I think the neoadjuvant is covered in another session. Breast cancer, as you all know, is a heterogeneous group of tumor comprising various clinical, morphological, different biological phenotype, with different behavior and response to therapy. And we are looking for early detection of breast cancer because cure is there and there is improved survival. 10-year survival is more than 90%.
Selwa, may I just interrupt? Please, can you mute your mics because it causes disruption.
Which mic?
A mic of our audience. All the audience, please, can you mute your mics?
The audience, I think the audience mic.
Yeah, in the audience, yes, Merhan Ahmed. Can you please mute? Yes, can you please mute your mics? Thank you, Selwa. Okay, you can.
Okay. Throughout the years, breast cancer classification is evolving. As you know, as you see here, the WHO classification. It's in 2003, it was tumor of the breast and female genital organs. Then from 2012, as a separate tumors of the breast, and then the last edition is the tumor of the breast also. This evolvement, the last, include integration of molecular genetics into the traditional morphological assessment so that we can provide understanding of what is under the tumor biology and guide for tumor decision or decision for treatment. So as you see, the molecular pathology in 2003, there is no molecular, emphasized only basic morphology. Then comes in 2012, introduction of the role of immunohistochemistry as a basic molecular profiling. And then they emphasize in the last edition the molecular subtyping into luminal A, B, HER2, and triple negative. And it is evolving. The epithelial tumors, it has no special type. It was called no special type in NOS in 2003. Then it comes to be of no special type in 2000. This is renamed. And this is emphasized more in 2019. And there are all 11 subtypes, special types. In 2003 now, it is 19 types added with different entities as separate entities like oncocytic tumors and neuroendocrine tumors as separate entities, mucinous and papillary. They are now as separate entities. So breast calcification based on pathological characteristics, that means the histological type of the tumor exactly, like is it in situ, is it invasive? I will be talking about invasive. What type of invasive? Is it the of no special type, or it is of a special type? And that the grade of the tumor, is it well differentiated, moderately, or poorly differentiated? It is grade 1, 2, or 3, and the extent and the spread of the tumor based on, and then the molecular subtyping. Invasive carcinoma is invasion of the tumor beyond beyond the duct or the lobules, breaching the basement membrane and infiltrating the surrounding tissue. And it's a heterogeneous type of tumors that can originate either from the lobules or the ducts. And the invasive ductal carcinoma of no special type is the commonest type. When we come to morphological evaluation, how we evaluate the morphology of invasive breast cancer, morphology still is a gold standard in primary decision for treatment, prognosis, and staging for the patient. And because we primarily evaluate microscopic features on tissue samples sent to us in the lab. This tissue sample can either be core biopsies or vacuum-assisted biopsies or excisional biopsy. There is different type of excisional biopsies like wide local excisions, different type of mastectomies. It depends on the stage and the facility within the hospital itself and the protocols used in that hospital. And the pathologists now are facing many challenges in breast cancer, especially with this advancement in molecular and advancement in the new treatment strategies in breast cancer. So morphology is the responsibility of the pathologist, because the pathologist is the responsibility of the pathologist. So the tissue samples, as I said, it can either, and for the core biopsies, there are certain protocols about the number of the cores and how to put it, and we describe the excisional tumor, the tumor irregular, how the consistency, the size of the tumor. There are grossing for mastectomy or excisional biopsy. It has certain type of protocols. The most important thing is fixation. Fixation is crucial in any tissue biopsy sent to the lab. And this should not be we should avoid delay in fixation. Specimens should be put immediately in 10% buffer formalin. And because we are facing this in Sudan, unfortunately, especially in excisional biopsies, mastectomies, there may be a delay till the end of the operation, because this will affect the tumor grade, it will affect the stage, it will affect also the markers, the immunohistochemical markers, because proper fixation is crucial. So how do we look for morphology? We evaluate, there are different areas of evaluation. Evaluating tumor differentiation and tumor extent, disease extent, how far the tumor goes. Tumor differentiation by identification of the tumor type according to the WHO classification, either This is an invasive ductal, this is an invasive lobular, or a variance of other variants of invasive ductal carcinoma based on certain cytological architectural features, and as well as a stromal reaction, and the tumor grade, how the tumor is differentiated from grade 1 to 3 according to Nottingham grading, and other features also in lymphovascular invasion, if present or absent, if there is in situ component, and present or absent, and even if it is extensive in situ component or what, stromal features now is coming up, like tumor infiltrating lymphocytes, focality of the tumor, bilaterality, also with after description of the growth. Then the disease extent, tumor stage, invasion of the tumor, the invasive tumor size, and infiltrating of the surrounding tissue, and assessment of lymph node status. And it is reported according to the standard data set or protocols for reporting. So pathological staging remains gold standard and provide detailed information for the disease extent using the TNM. If, for example, this is an invasive ductal carcinoma, this is a core biopsy. As we can see, there is sheets of cells undifferentiated. We cannot see this is a low power. Then we come closer, we can see there are sheets and nests of tumor cells with some tubules, and there is high grade in this DCIS, and there is a desmoplastic reaction. And the tumor is infiltrating the fat. Here is forming solid sheets. For the lobular carcinoma, this is a classical type, what is called Indian file. It is a discohesive cells, like Dr. Sarah said. The cells are uniform, discohesive, separated from each other, and there is a normal duct here in the center, and this is surrounded by the tumor. And we need to sometimes differentiate this is ductal or lobular by ecadherin and other markers. Like also, invasive lobular carcinoma has variants, pleomorphic, solid variants, and we need to differentiate from the features. Other special types of invasive breast cancer, like mucinous carcinoma or tubular or metaplastic carcinoma. How do we grade the tumor? We grade the tumor by numerical scoring. This scoring, we give 1 to 3 for tubular formation. If there is a tubule, the percentage of the tubules, the nuclear pleomorphism from 1 to 3, and the mitosis from 1 to 3. And then we come with the sum up of these scores. Tubules more than 75, this is 1, to 10 to 75%. You see this a wide range, and 3 is less than 10% tubules. Nuclear pleomorphism, mild, moderate to high, and mitosis 0 to 9, 10 to 20, more than 20 for the high grade. So we make a sum up for these scores. 3 to 5, this is well differentiated. This is grade 1, and 6 to 7 is grade 2, and 8 to 9 is grade 3, like here. This is tubules, more than 20, tubules more than 75%, and uniform nuclei of Schuyan, and the mitosis is less, up to 9. And this is moderately differentiated. There are some tubules between 10 to 75. The range is very wide in the grading of this pleomorphism. Then for the high grade, it is we call it the nuclei are pleomorphic, and there is a lot of mitosis. We can even see it here, a lot of mitosis, and there is a cutoff for mitosis. Sometimes we can predict some histological features, can predict some aggressiveness, although this is not taken alone by itself. For HER2 positive invasive carcinoma, where there is a lot of comedial necrosis, where in triple negative, it is high grade. This cannot predict morphology by itself, cannot predict. You can see this is an aggressive type of tumor, but it cannot predict behavior. We need to take into consideration that the other features like evaluation of the images and evaluation of other clinical and molecular factors for aggressiveness. Now it comes to the now in the WHO, the recent WHO, the 5th edition, the tumor microenvironment or tumor infiltrating lymphocytes. And this tumor infiltrating lymphocytes actually comes up earlier on by Paget, who make a hypothesis that the environment, tumor environment is important. And then is crucial for tumor growth and progression to metastasis. And they said that the tumor infiltrating lymphocytes are part of the tumor microenvironment, and it is important as prognostic and predictive value, especially in triple negative breast cancer and HER2 positive. And a lot of papers evaluated how roughly to evaluate tumor infiltrating lymphocytes. And now there is a recent paper here evaluating it manually, visual assessment in the peritumoral stroma and within the borders of the invasive edge of the carcinoma. And we score the average percent of the stroma lymphocytes with the entire stromal area of invasive cancer. This is subjective. We'll talk about that then. Lymphovascular invasion, if there is invasion of the angioinvasion, and then perineural invasion, and of course, then the resection margin. We have to tell this is positive or negative because we make an ink so that we can say this is an invasive tumor involving the margin, and we can tell how far, if it is free, how far the free margin from the tumor, and this is important. Also, if there is lymph node metastasis, of course, in excisional biopsies where we have either, if we have sentinel node or we have lymph nodes, other lymph nodes, we take all nodes and we calculate what is the number involved over non-involved, and sometimes it is difficult to see metastasis, and we need to make or to do immunohistochemical stains like pancreatin to check if there is metastasis in this lymph node. Then comes the era of molecular markers in reporting invasive breast cancer. And then because morphology by itself cannot predict behavior, biological behavior, or the response to tumor. This is what discovered the importance of hormonal therapy was discovered in the early 60s. Then it was followed in the 90s by the discovery of anti-HER2 or Herceptin for the management of metastatic breast cancer. This is in the early 90s. Now it is routinely used, the ER, PR, HER2, and KX7 as a routine for subtyping breast cancer into luminal A, B, HER2, and basal-like. Luminal A, these are ER positive, PR can either be positive or negative, HER2 negative, and they are slowly growing tumor. KX7 is low proliferation, and luminal B, ER positive, HER2 positive or negative. But the difference, there is high proliferative index compared to luminal A. HER2 enriched, negative for hormonal markers, positive for HER2, basal-like, or triple negative, it is negative for all markers. Why it is important to do this in every breast cancer? Because it is of prognostic and predictive value. The histologic grade in HER2 and basal type is very high, while it is, and the recurrence rate is high in those who are HER2 positive, and those who are HER2 positive, they don't respond to hormonal therapy. They need HER2 Herceptin plus chemotherapy, while those luminal either A or B, they are of low grade, they are low risk of recurrence, and they respond to hormonal therapy. In the lab, how can we calculate or how can we estimate this is ER positive, ER negative, HER2 positive or negative? It depends on, because ER/PR is a nuclear marker. It is positive in the nuclei. It gives the brown color. It depends on the chromogene you are using, but usually you are using the brown color. It gives positive, but we look for brown color in the nuclei. This is a positive. And we score it according to the intensity of the stain itself, as well as the percentage of the tumor that is positive for this estrogen, either estrogen or progesterone. Usually more than 1% is considered positive, yeah, weakly positive, more than 1%. But from this score is out of 8. If it is this score for proportion of positive cells from 0 to 5, and for the intensity from 0 to 3. You see that this mathematics is coming up in histopathology. And we score it 0 to 1 is negative, 2 to 3 weak, 4 to 6 moderate, and 7 to 8 strong, positive. Then HER2, this is scored from 0, 2 plus, 1 plus, 2 plus, 3 plus. 0, no staining, or faint staining in less than 10%. 1 plus, faint or barely membranous. HER2 is membranous stain, while the hormone AR/PR is nuclear stain, membranous stain. Then invasive tumor cell, it calculates, this is incomplete, weak to moderate, and in HER3 plus, it is strong, circumferential, complete membranous staining. In HER2 is equivocal, and we need to do another test to confirm this is positive or negative, because patients need to benefit from the treatment with Herceptin. And by doing in situ hybridization or by doing FISH to see the amplification of or overexpression of the marker. HER2 positive breast cancer, they are highly aggressive, have high cytological gradients, and they have tendency to go to the lymph nodes, even if it is diagnosed in early stage. This is FISH, and then cytohybridization. They can detect the amplification by using fluorescent DNA probe to bind the gene within the cancer cells, with using a special microscope to count the number of HER2 gene copies to see if there is gene amplification. What is the clinical utility of this overall? Luminal A and luminal B, they have good, they are the commonest and they have good prognosis. HER2 up to in 15 to 30%, it's can be good or bad, it depends. While with the bad type or is the trypin negative. And the luminal A has a good response to hormonal therapy, unlike luminal B. Luminal B has high proliferative index. And for HER2, they don't respond to hormonal therapy. They respond to chemotherapy, unlike trypin negative. Even with chemotherapy, there is a problem with a response to treatment. So other markers can be used, as I said before, like E-catherine or beta-catenin or P15 for lobular type of tumors. And now the PDL1 in trypin negative to see if there is, because they are targeted for immunotherapy and epidermal growth factor also in trypin negative, and basal markers, some myoepithelial markers, and even, as we said, cytokeratin for lymph node if to assess metastasis if it is not seen. And the genetic testing is can be done in those who have predisposition for or suspected for having familial or hereditary cancer. Staging, then we come to the pathologic TNM staging, which remains the gold standard that provides details about confirmation of the tumor size, infiltration of local structures, there is lymph node status, and if there is metastasis or not. And as well as you can see, survival is very good in those from stage 1 to 2B. Reporting for breast cancer, standardized structural pathology reporting is essential. That needs the precision of information in breast cancer care. Many data sets for pathology reporting all over the world are there. And the ICCR now is trying to ensure consistent format, because all this format, they concentrate on the same core and non-core data, but the ICCR now they are trying so that it can guide treatment, guide patient management. Report for core biopsies for the B category size, and for invasive it is B5B. And for the pathology report, we have to tell the type, if there is in situ component, the type of the tumor, the grade, if in situ component, and we do also in the core the immunohistochemistry and the molecular type. And in core is diagnosis or the grade can be different when the tumor is excised. So usually we put a comment on the report that definite grading is reserved for resection, because there are limited information, because the core biopsy is a small biopsy, and sometimes the histological type, nuclear grade estimation is one of the limitations. And the same for reporting excisions. In addition to what we said before, lymphovascular invasion, perineural invasion, and in all we do immunohistochemistry. This is now part of the typing. Although the morphology is a gold standard, it has a challenge. There is a challenge with morphology and immunohistochemistry, because sometimes the heterogeneity of the tumor type and the grading reproducibility, or it is a subjective how to grade. Because grading system, the tumor grade, the tubules, more than 10 to 75%. There is inter-observer variability in grading. And the tumor micro, there is a lot of research about tumor infiltrating lymphocytes and how to calculate in tumor infiltrating lymphocytes and how to score it. Also, immunohistochemistry depends on technical, can be there is pre-analytical phase technical problem or fixation problem, because we make sure in the lab that we have proper quality assurance, validation of the test for the markers and all these technical parts, and also the scoring. As we showed before, I showed before how to count the ER/PR positive, HER2 positive, +1, +2, +3. It is, and there is a semi-quantitative, there is observer dependent, and it's subjectives. And now people are moving to trying to count this by either using AI or other scoring system. Although, and now immunohistochemistry is evolving and updated and revalidated continuously, and classification is now integrating molecular and genetics to traditional morphology. And now the current interest focus on single gene or multi-gene assay to quantify, to stratify breast cancer into distinct subgroups for the decision of treatment. It comes up now the era of HER2 low or HER2 ultra low. HER2 low, as I showed before, HER2 is scored 1+, 2+, 0, 1+, 2+, 3+. HER2 low is first discovered in but there is a paper by the American Society of Clinical Oncology in 2018 put a guidelines refining the definition of HER2 low, and that it is scored HER2 score 1+ or 2+ with a negative-ish and fish. And HER2 ultra low, this is a newer category, scored, they put also 0-ish negative phenotype. So very faint HER2 staining in less than 10%. This is in the 0. Why they are talking about this? Why they are concerned about very low and low HER2? Because patient could benefit from novel anti-HER2 treatment or antibody drug conjugate called DXd, and it is correlated with less aggressive cancer indicators. There is no prognostic, but patient can benefit from drugs of the anti-conjugate, antibody drug conjugate. But the problem with how to score this, there is controversy about scoring this HER2 low and ultra low. A lot of researches, a lot of papers are now presented in conferences and in the internet. A lot of papers about it. Controversies in this refinement and reproducibility of the test is self-threshold, and there must be quality measures to record how to assay this HER2 low and ultra low in the lab. This is low, the ultra low, and the low. How many minutes I have, Nadia?
Salwa, I was just going to interrupt you because you're almost there, but I will give you, I think, less than 5 minutes. You will finish.
Okay, I will go over.
Yeah, I know you.
Okay.
You are almost done.
Okay. Other prognostic indicators. Thank you. In tumor infiltrating lymphocytes and PD-L1. Tumor infiltrating lymphocytes prognostic predictive value in triple negative. Now current research going on automated tumor infiltrating lymphocyte scoring. And for PD-L1 now, they are using immunohistochemistry as well as gene expression profile. Immunohistochemistry is used PDL in metastatic triple negative, so that patient can benefit from immunotherapy treatment. Also, there is a research in subtyping triple negative into basal-like Yes. For treatment. There is the recent development. Nottingham Prognostic Index is known as a prognostic indices because it can predict survival. It's not routinely used, but now there is update in trying to validate it. Is effective or not.
Please, excuse me, Salwa, please mute your mics. It disturbs the presentation.
How can I talk?
Yes, yes. Yes, اتفضلي سلوى. Salwa, open your mic. Salwa?
Okay.
Okay, Salwa, I just needed to remind people to close their mic.
Okay.
Sorry for interruption.
I can't see.
We can see your screen.
You can see my screen? Okay.
Yes.
The future is towards
can you put it on slideshow? Yes. No, we can see your screen.
Okay. Now, multi-gene assay, liquid or biopsy circulating tumor DNA. I think Arwa will talk about digital pathology and AI and personalized report decision support. And the genomic risk profiling, this is a new, this is a trial. And he is multi-gene assay signature, trying to verify low risk versus high risk. Low risk, only they can benefit from endocrine, while high risk, the patient, they can have, in addition, chemotherapy. And different types of genomic risk, especially in HER2 and luminal, predict risk of recurrence, distant metastasis, and early relapse monitoring. And the spatial transcriptomics, this is a set of technology that map the gene expression within an intact tissue sample, preserving the spatial context of cellular activity. This data provide transcriptome data in a format for bioinformatics so that it can be analyzed of gene expression within the tissue context. This is this new technology. And the issue is to map the tumor heterogeneity and guide immunotherapy combination. And the circulating DNA, it's originate and malignant cells can shed in the bloodstream, and this carrying DNA that have a specific genetic mutation, it is used in metastatic setting as well as in early stage recurrent detection. And in summary, pathologists are facing many challenges in breast cancer diagnosis nowadays, especially with advancement in technology and rapid development of breast cancer treatment. Breast cancer classification is integrating molecular genetic data with morphology. Patient pathological diagnosis remain the core standard for establishing diagnosis and providing prognostic predictive value with the use of up-to-date classification. ER/PR, HER2, KI are routinely used molecular subtyping, and the emerging technology and the shift of multi-omic risk adapted precision medicine hold a promise for deeper understanding of tumor biology, guiding breast cancer treatment and prevention. Thank you.
Thank you, Selwa. That was a very wide scope, and it revised our breast pathology diagnosis in the lab, as well as the advances that are really going to shape our future and going to make it easier for us to give those detailed reports. Thank you, Selwa.
Thank you. Thank you.
Selwa, can you
Can I
unshare?
unshare?
Yes,
Okay.
please. Thank you.
Sorry, Dr. Nadia, may I just make a suggestion?
Yes,
It's just I know
you're welcome.
the newcomers always forget to mute their microphone, and I noticed there is one host for this meeting. If the host can take the charge or make co-host with them, they can mute people immediately without asking them, because there is loads of interruption. So if the host can
Yes.
mute 2 or 3 co-hosts with him, and they take the responsibility of
دكتورة نادية
muting.
ممكن أعملك co-host معنا؟
Okay, and let me know how it's done. If you are there, Riham, you can do it.
Riham, you can do it, I think.
أيوة يا دكتورة، أنا هعمله وهعمل معي برضو co-host عشان يعني كيس أنا ما انتبهت بس.
Make دكتورة نادية with you. Yes.
Okay, tamam. Just let me, Riham, can you show me how to do that?
أوكي دكتورة، بس مجرد ما تفتحي ال participant, you can see that there is a microphone and a camera.
Yes.
Yes, just click on the microphones. يعني when it's green, that means it's open.
Okay, okay, fine.
You can try to mute me now because my mic is open now.
Just wait.
Okay.
Yeah.
Thing is, I can see you. Yeah.
Yeah. When I speak, I should be.
No, it's not there.
Just a second, دكتورة نادية.
Okay, okay.
Like looking at the participant now, there are many mics which are not muted. You can mute all of them. So there are at least.
It tells me ask when I click on an open phone. Okay, yes, now it's working.
Now you are a co-host, دكتور.
Okay, tamam. Yeah, okay. It's working. Okay, Arwa, you can share your screen.
Okay.
Yes, we can see your screen, Arwa. Yes. Are you ready to start? Shall I introduce you, Arwa?
Yeah, I think so. Can you hear me?
Yes, we can hear you clear.
Okay.
Arwa, okay. Arwa is I shall say it, Arwa. Arwa is my daughter in pathology. She is the current head of histopathology at the National Public Health Laboratory in Khartoum, Sudan. STAC laboratory, as we say. She also works with me at Soba University Hospital. She's affiliated to Al Muqtaribin University and is a mother of 5 children, I should say that, just like me. And we huggled things together in pathology and at home. تفضلي أروى, you have an interesting topic.
Okay. Good morning, everyone. I would like first to sincerely thank Dr. Sarah and Dr. Salwa for very nice and very comprehensive talks. And actually, Dr. Salwa mentioned me. Thank you for doing that, Dr. Salwa. I just would like to say that Dr. Salwa and Dr. Nadia were there with me. I actually was looking up to them as my teachers, and then I joined their struggle to maintain the pathology service for so long, and now we are actually colleagues in so many places, in the histopathology board, the consultancy board, and so many areas. We were really struggling until the war, and now we are really left to in thin air. Actually, we disappeared. I feel like we disappeared. Okay. Thank you, Dr. Rabab, and everyone who helped continuing the الجمعية السودانية لتطوير study, and now adding women health to that. I will not take long. Just let me enter my topic, which is based mainly on the pathological discordance and an introductory to the era of artificial intelligence. So to start with, I think the artificial intelligence in breast pathology is like a bridging digital tool that helps alleviate so many things, including the pathology. So the key points of my talk will be about discordance, about digital pathology, about AI in breast pathology beyond digitization, and discordance, how it will alleviate and be augmented by the use of AI or artificial intelligence. So pathological discordance. To actually define pathological discordance, we have so many types of pathological discordance. So it might be defined in several ways. First, we define the pathology radiology discordance, where these are actually classmates of us, the radiologists, because we are both standing in the diagnostic part of service. And discordant cases occurs when the pathology result from usually it's a biopsy, because the section has little of to it, but the pathology results in a biopsy, it does not match the radiology or the imaging classification. Okay. And the other thing is that certain lesions have got poorly defining features in radiology, and then they are actually defined by pathology, which makes a little bit of pathology radiology discordance, like the ADH and the flat epithelial atypia, fibroepithelial lesions, papillary lesions, and the lobular lesions. I think our colleagues in yesterday talks, they talked about this. And they also talked about a specific entity named radiologically high risk or complex lesions. And I would like to take this as an example for the imaging pathology discordance and talk a little bit about it. And I refer to, I had a reference from the College of American Pathologists educational material, which shows the pathology radiology correlation from a radiologist. And it talked about radiology high risk or complex lesions as though. They say that these lesions are either due to interpretive issues of the radiology or sampling error that makes the radiology not actually sample the area of their interest. So there is a pathology radiology discordance, or there is an adjacent cancer to the thing, which makes it the radiologist will be focusing on the cancer, and the pathology report comes as, I think it's also a sampling error, and the presence of precursor lesions, which actually vague or even no radiological appearances, that diagnostic appearance. So from a pathological point of view, these high risk of complex lesions fall into one of these pathological categories, which is the atypical ductal hyperplasia and the lobular pathology as a whole, ranging from the lobular atypia to the lobular carcinoma and even the invasive lobular carcinoma, but mainly these two. The flat epithelial atypia, which is this plastic lesion, and it's actually really a mysterious lesion that's not yet classified with the DCIS fully, but and not with the atypia fully. So it's in between. And the mucinous lesions, as we all know, it contains a lot of mucin, and mucin is really tricky on radiology. And the papillary lesions as well. Some people on the radiology part, yesterday they talked about the papillary lesions, although they have very characteristic features, but you cannot tell which is which on the radiology. So it is a source of discord. Phylloid tumor as well, it needs pathology to say whether it's benign or fibroadenoma, or in the other end of the spectrum, where is their borderline malignant or the polysarcoma area. And the radial scar, of course, everyone knows that it's a radiological problem because it looks very much like basic carcinoma, but in the histopathology, it comes discord. So this educational material from CAP showed some percentages for the frequency of the pathology diagnosis in discordant cases, and showed the ADH, which is the least risky lesion actually, as the most common discordant. So I have a case which I brought from the same material. It's about a 49-year-old woman with metastatic colonic cancer, which she initially presented in the year 2011 for annual screening mammogram, which was negative. And this is the mammogram. And it actually showed in the educational, in my reference, as this. And it showed with these circles in a certain area. I think from yesterday talks, this is like a dense breast. Maybe, and there are problems with the dense breast, and they were addressed by our colleague radiologist yesterday. So this case had been in a screening program for mammography since 2006. She never came and joined the screening program until the year 2011. So there is no mammogram in between 2 years. The pathology report for the case for the excised lesion, this lesion was excised, and the pathology report was fibroadenoma, which is benign, and it was concordant with the radiology report, which also stated benign. So this is actually concordant. Where is the discordance? Okay. Post-biopsy mammogram showed the area of the lesion as here, as shown here. I'm not a very expert in radiology, so please, any of our radiology colleagues, you are really free to comment after the presentation. And this is actually the photo of the case, which showed, which actually stated fibroadenoma. And to me, and maybe most of our pathologists, maybe this is not much of a fibroadenoma. I think this is a benign phylloides. Maybe Dr. Selva, Dr. Nadia, and other pathology colleagues will actually agree with me.
And
This
for
is
us,
the,
doctor, sorry for interruption. For us, it is also not typical of fibroadenoma radiologically.
yeah, thank you for saying that, because I found this case actually really confusing, and that's why I chose
No,
this.
I will not report it as fibroadenoma totally. No, it is suspicious.
So
It can be,
for
as
you.
you mentioned, it can be adenomatoid lesion, fibroadenomatoid lesion. Sometimes is a mimicker. Okay, more mimicker than fibroadenoma, but it is not typical fibroadenoma. It can be atypical fibroadenoma, but it is not a typical fibroadenoma.
Okay. So this is actually the irony in the case, actually, because this also does not look like fibroadenoma to me. It looks like benign phylloides. So let's see what happened to
exactly.
Yeah, the patient returned in August 2014 with palpable right breast lump, which is shown here. And strange enough, they didn't do anything. They just do the diagnostic mammography and ultrasound, and actually didn't do surgery until they image again in January, which is a few months later, in January 2015, with the lesion becoming this big, and the pathology said phylloides tumor. So again, concordant result. And this is the image, and the image, to me, actually, this one at least is a borderline phylloides tumor. So as we see, although the radiology and the pathology were not discordant, but I think the patient did not benefit from their concord. I think everyone must actually rethink again. If they talk to each other, I think maybe they can find better result for this patient. So another part of logical discordance, which is the major part to me, is the pathology discord. So what is this specifically? It is when there is disagreement between two pathologists evaluating the same sample, or same pathologist using different methods, or maybe different pathologists using different methods, like light microscope versus whole slide image. And this can, the pathology discordance can range from a minor discordance, where there is an interpretation difference, but it does not reflect into the patient management, to a major discordance, which actually alters the patient management in a negative way. So in pathology discordance, we have minor discordance or major discordance. And of course, the inherent limitation of biopsy versus excision or microscopy. Because in biopsy, there is always pathology discordance because of the limitation of the material, the tissue material. In excision, there is actually more agreement, and inter-observer variability will be less in an excision biopsy or in mastectomy, as we all know. So biopsy is the major site for pathology discordance. This is also a reference where I actually saw a huge systematic review with meta-analysis, which actually looked into the diagnostic concordance and discordance in pathology in aim to find the reliability and validity of digital pathology as a tool to enter the lab of. So review examined a total of 10,410 histology samples, and the overall concordance agreement percentage was 98.3% between diagnostic biopsies and mastectomies using light microscope and using the digital versus the whole slide image of pathology. So it's a great deal of concordance, actually. But a minor percentage, which is less than 2% of cases, with a total of 546 major discordances were reported. And we actually define the major discordance as the discordance where it actually affects the patient management in a negative way. So what are the causes of these major discordances? Over half of them were related to assessment of nuclear atypia and the grading of dysplasia and grading of malignancy. And actually, Dr. Salwa was really very comprehensive in saying the problem with grading. So, at 26% of the major discordance was due to challenging diagnosis, and this means that the problem is within the lesion itself. The nature of the lesion is actually challenging and has got hazy criteria like atypical lesion or B3 lesions in the biopsy, of course. Also, another challenging diagnosis was the presence of focal invasion or microinvasive carcinoma. Another small percentage or a smaller percentage, 15% of major discordances was found due to identification of small objects, which is really difficult in digital pathology or whole slide image examination, like, for example, calcification, mitosis, and micrometastasis, like single tumor cells within a lymph node or TILs, like that, as Salwa mentioned earlier. So I just would like to say that all these discordances were actually in favor of the light microscopic diagnosis by histopathologists against the digital or the whole slide image use. Okay. So I would like to take the nuclear atypia as an example of pathological discordance and talk a little bit more about it. And I actually has got this reference from the famous Professor Imad Raha, who is really an eminent professor in the field. And this paper actually classified atypia in breast pathology in two classes: cytonuclear atypia or architectural atypia. So the cytonuclear atypia is actually used in differentiating epithelial proliferative lesions like the usual ductal hyperplasia versus atypical dysplasia and DCIS. And this was actually explained very well by Dr. Sarah earlier today. And the invasive carcinoma grading system also is an area for cytonuclear atypia to enter the grading system, as explained by Dr. Salwa, and also the stromal cells in fibroadenoma versus phylloides tumor, and to classify phylloides tumor into benign, borderline, or malignant. So the cytonuclear atypia is used in the differentiation between these three categories of tumors. And the architectural atypia is used in blood epithelial atypia to differentiate it from the atypical ductal hyperplasia or DCIS. So I would like sum up or the summary of the use of atypia in defining pathological diagnoses is that the interpretation of atypia is inherently subjective. And this actually agreed by Dr. Salwa in the previous presentation, which is why, because it represents a morphological continuum which reflects the biological spectrum. So this is inherent subjectivity in the interpretation. And the other thing is there is lack of standardization in defining atypia, which further augments the diagnostic pathology discordance in breast pathology with potential implications for patient management. I mean, leading to major pathological discordance. So, standardization of atypia criteria for diagnosis must be considered before delving into a digital pathology format as a primary diagnosis. Because in the previous case, we're talking about digital pathology used as primary or secondary, mainly secondary, I mean after life. So these are photographs. I don't think need to talk more about this. And the A, of course, represents normal pathology breast, normal breast with normal variation. The nuclei are very regular and they represent the normal ducts. In B, this is actually a usual ductal hyperplasia with a little bit of orientation, the streaming, but still there is no much of atypia of the eye. And the C, D, and E, they represent actually ductal carcinoma in situ, ranging from mild degree of nuclear atypia to moderate degree of atypia to severe or high grade of nuclear atypia with multiple nucleoli and very vesicular nuclei. And the FGH actually are from the malignant or invasive carcinoma, which ranges from also mild atypia with microcalcification and to moderate atypia with variation in size and shape, to marked atypia, which we call it pleomorphism, with actually different sizes and shapes, and multiple mitosis. So again, about clinical logical discordance, I actually refer to this study, which actually involved a huge number of breast cancer patients looking at the clinical and pathological stage discordance. So the other or the third part of pathological discordance is with the clinical people. So clinical pathological discordance, which is defined as a lack of agreement between information gathered from the patient clinical evaluation, like physical examination, imaging, and so on, with the final pathology result obtained after surgery. So this is the different set of pathology discordance. And among the huge amount of patients with the stages from 1 to 3 breast cancer, so they omitted the stage 4, and they also omitted any case which had neoadjuvant therapy, previous surgery, or any type of treatment. So these cases, all of these patients were actually breast cancer patients, were diagnosed clinically and by imaging, and then after the pathology, after the surgical removal of the tumor, the pathology came discordant with the clinical decision. So this discordance actually was mainly into pathological staging or into the stage. So there is upstaging or downstaging in the tumor grade from 3 to 1, which is really very long way to go. And in the histology, and these are the causes actually, where actually the grading, which is really addressed by Dr. Salwa, it has got very huge challenges because we can find different grade in the whole mastectomy or the whole tumor, and which is different from the or discordant with the clinical evaluation. So tumor grade, the histology type, lobular versus focal, and the biomarker state. It HER2 negative specifically showed a lot of clinical pathological discordance. So, and of course, the inherent discordance of margin status, the clinician, by their naked eye, they think that this margin is clear, and then the pathologist breaks the bad news, and some clinicians almost need to kill the pathologist for saying margins are false. So, clinical pathological discordance, I would like to talk about or take an example of tumor histology, like in invasive ductal carcinoma versus invasive lobular carcinoma. To us, as pathologists, this is really very obvious. The difference is really very obvious. But for the clinicians and the radiologists, maybe things will mix up a bit. So I will not go more into the details of this because Dr. Salwa have done a great job in this. And I will finally finish or close my talk about the pathological disorder and by saying, why does it matter? Why does the pathological disorders as a whole matter? Because breast pathology is actually central to early cancer management, and actually it is still the gold standard of diagnosis, and yet significant discordance exists. These discordances, example, in grading, in margin status, in distinguishing atypia versus CIS, and DCIS versus invasive lesions, and invasive lesions, fully invasive versus micro-invasive. So discordance will directly impact the surgical planning, the adjuvant therapy, the prognosis, and actually main to all of this is patient anxiety. And patient anxiety is actually when they find that their clinician says something and the pathologist says another, or the radiologist says something and the clinician says another, or the pathologist says another. It's actually usually we, the pathologists, are the discordant people. Usually the clinicians and the radiologists will actually agree with each other, but we are the discordant people. And so this might be setting the stage for the digital pathology and AI tools entering this field. So maybe to alleviate a little bit of the mathematics that we need to do and alleviate the inter-observer variability. So my end of talk will be actually an introductory into the world of AI, trying to explain as much as I can in a holistic fashion, not very detailed. So digital pathology, when we say digital pathology, there is the term digitization. And when we say digitization, we mean making like digital. So digital pathology is like digitizing only one part of the whole process. This means digitization. So make digital only one part of the process. Then there is the term digitalization. So we take a whole process and digitize every step of that and make a whole system of a digitalized process. But AI is actually a complete whole story. Although digitization and digitalization are actually the foundation of AI, but in AI, we have additional machine learning and deep learning concepts. So we will see. I will just take you back a little bit into the regular flow or workflow in the diagnostic surgical pathology with pre-analytical, analytical, and post-analytical phases. The clinicians are in the pre-analytical and the post-analytical, and the pathologist is in the analytical area. So the patient will arrive for clinical evaluation, and this clinician will order collect a specimen or not collect a specimen If the specimen is collected, then it's given some kind of identification, and then it's received in the lab, where it is given another identification, goes through accessioning, gross evaluation, histology processing, microscopic evaluation, and report transcript, and then the final report verification. This final report will return again to the clinician to tell the patient about it and take action or don't take action. So in the digital pathology era, I just brought this slide to show you the difference. Because if you have this digital system of a whole slide image, some labs, this is actually the regular cassettes that we use in the regular traditional pathology practice. They are all the same size, and we need actually to take small pieces of tissue to fit into this standard size of a cassette, which will actually make it eligible to go into the processing steps. If you are in a digital setup, sometimes they use larger cassettes. You see these slides? These are for the going into the whole slide image or the slide scanner. And people here might use larger sizes of cassettes to actually fit the whole lesion within the cassette, and then get a whole lesion image in a whole slide image, okay? Like here. So this is the whole lesion put in a little bit bigger cassette, and then screened or actually scanned by the slide scanner, and then you can visualize in this nice monitor. So digital pathology is actually the foundation step for AI era. To define digital pathology is simply converting glass slides into high-resolution whole slide image for visualization and sharing. So it's just one step of the process. The light microscope reading is actually converted into whole slide image and monitor reading. That's it. So the key components are actually the slide scanner, so to scan the slides. Image management software, which is a big problem for the digital pathology, because you really need huge space to manage the software and to secure huge space or storage, secure the storage space with cloud archive, and you need an on-site or remote viewing platforms like in telepathology, or without telepathology, just in the monitor within the same lab. So you need slides to be scanned, the images to be prepared, and then you have to have secure storage and archive, and then you visualize on the monitor. What are the benefits of digital pathology? It actually makes sharing with or consultation more easier with reduced turnaround time, and it is very, very, very useful in training, education, and archiving, because your archive can be accessed from anywhere in the world. So quality control is also easier when we have digital pathology. But what are the limitations? You need a digital microscope, you need a slide scanner, and it does not much solve the inter-observer variability, because at the end of the day, the pathologist will read either the slide on the light microscope or the whole slide image, the monitor, or a telepathology. So the digital pathology workflow, when it is actually compared to the traditional workflow, we see that, excuse me, do I have much time, or am I okay with the time, Dr. Nadia? Okay. So we have the differences between the traditional and the digital workflow is that here, the first step of both digital and traditional is the same. So you take a slide, take a section of the tissue, the pathology tissue and put it in the slide. So the processing, the staining, everything is the same. For the traditional pathology, it will be all human and reach a microscope, which is read by the pathologist to reach diagnosis. But here we add a step of digitalization of this slide into a whole slide image and have got digital archive plus the manual archive. And here we can actually share this whole slide image with someone else or read at home or something like this. So you read it through the monitor by a pathologist again and give your diagnosis. But the automated image analysis, this is the area for AI, actually. So toward complete digitization and beyond. What is the setup needed for giving complete digitalization? So using computational models to analyze the whole slide. It's not just the pathologist to read the whole slide image on a monitor. No, you use computational models. And it has huge capability, actually, because there is automated detection and classification of tumor versus benign, DCIS versus invasive, and this is not actually detected by the machine. No, it just helps you actually count mitosis, find the very small amount of atypia present, and actually calculate everything for you to actually then interpret and reach a diagnosis. It's not making the diagnosis by itself, it just gathers the information in and the percentages as actually was introduced to you by Dr. Salwa. Everything is like percentages, numbers, and things like that. So the percentage count and the number count will be very better by automated detection. The grading and quantification, counting mitotic figures, nuclear features, and especially the Ki-67, really very difficult to read Ki-67 IHC and reach percentage. It's really very difficult. And the hormone receptor status also, there is subjectivity in intensity of color and the percentage of the nuclei that are colored. So the prognostic prediction models by integrating pathology, radiology, and genomics with the clinical data. So this is a multimodal AI. This is a major capability where you can integrate all the pathology data coming from the automated detection and classification and the observation and interpretation of the pathologist, and also with the radiology information and the genomics and maybe transcriptomics and the clinical data, everything into a multimodal AI, and then you get a model of prognostic prediction or individualized medicine. So this is a diagram that shows how the digital pathology differs from the whole digitalization setup. So in the digital pathology, the histopathology slide is converted into an image, and the pathologist, instead of reading in a microscope, will read in a monitor, okay, and then reach a diagnosis. This is the digital. But if you are in a whole setup of digitalization, then the pathologist will observe here and actually annotate certain regions and certain cells and send them for AI processing to counting, making percentages, gathering data, processing everything. And then the machine will learn whatever you give to it and give you better understanding and better data to reach a final, very better diagnosis and prognosis with high precision and accuracy of details and quantification. So,
Arwa, may just you would be finished in about 5 minutes. Is that okay?
Yeah, I think it's very okay.
Okay, tamam.
Okay. I would like to again try to define the artificial intelligence and or define the area of artificial intelligence in pathology, because AI, or the full-blown digitalization world in pathology, is rapidly transforming the breast pathology by enhancing the diagnostic accuracy, the grading reproducibility, as been mentioned by Dr. Salwa, and actually the workflow efficiency and reduction of the turnaround time. So AI integrates histopathology also with radiology and clinical data, offering multimodal models and improving the risk stratification and personalized patient care with more consistent pathology, surgery, radiology. So we can actually do more robust MDT meetings to give highly useful patient management strategies. So what do we need to reach a full artificial intelligence era? We need integrated hospital digital workflows. So these are software, which are core systems for artificial intelligence. Number one is the LIS, which is the laboratory information system, which manages the lab workflow and the pathology reports man-free. So everything is in the digital system. And the PACS, which is the picture archiving and caping system, which stores, shares the images between radiology, pathology, and pathology hotline images. And again, we need for the hospital whole system, we need the electronic medical record where the patient full digital chart is present and will be very helpful in tumor boards and MDTs. So the advantages over basic digital pathology, it actually reduces the inter-observer variability because there are so many the machine learning and the processing of all the percentages and classification and things like that, provides explainable quantitative outputs and potentially standardize the pathology reports globally because we can exchange everything. So disadvantages are really the high cost, and of course nothing is 100% perfect. But this is just to explain the systems, the core systems. In the first column, you see that the hospital has a core electronic management of the patient, and this will lead to the admission is actually electronically made, the order for electronically made, the reception of the slide or the specimen is also electronically made into the laboratory system, and then the processing, which is not omitted actually, the processing and emergence of glass slide, and then the monitor or scanning of the whole slide image, and then you go into the archives, the artificial archives, and the whole system of the machines and the processing of the machine, and then reporting finally, and the report will also be within the hospital management system. So the workflow will be from image acquisition, maybe by a digital microscope, into processing and into different levels of the same slide, leading to image analysis and defining the hot areas, and then classification of each of the findings, and giving the pathologist result report with quantitative and qualitative analysis of what is in this slide, and then the pathologist will read and decide on the report. I just want to explain the artificial intelligence is actually any technique that enables computers to mimic human. This is the holistic approach. Inside that, we have the machine learning, where the techniques that allow machines to learn by extracting insights from data. So whenever you enter data into the machine for processing, it will learn something and store it, and then again, it will become better and to reach a final depth of artificial intelligence, which is the deep learning, where there are techniques to artificial neurons being present in the place and help you with vast amount of data being processed and delivered to you as a pathologist. So does this augment or alleviate the pathological discordance? Of course, if we have the traditional discordance, it's just a human variability. If there is AI contribution, then there is high degree of reproducibility, accuracy, and quantification, and human plus AI will be the best hybrid model to alleviate the discordance. So instead of a simple slide, we have a multiphoton microscopic image. Instead of H&E, slide reading by light microscope, we have feature extraction by the AI models. And instead of just inter-observer or second opinion approach by human pathologists, you have the ML platforms which will give you deeper data and rapid detection of so many things with quantification, and then gives it to the same pathologist to reach a final, more accurate diagnosis together. So this is the case example where there is a difficulty in low-grade DCIS versus ADH, which is an inherent discordance. And the AI heat map here, so here are the core biopsies. The heat map will actually show all the areas that are of interest and will actually identify the abnormality within the heat areas and quantify them and give you data with quantification like here. In the normal setup, it's just you see that by your naked eye and you are actually stuck. Can I diagnose DCIS on this small amount of tissue or defer it? So here it will become quantified and the actually problem will be solved. So does it have a multidisciplinary impact? Yes, there is a multidisciplinary impact of AI. So in radiology, it improves and empowers imaging and also the communication between each and everything. And in surgery, it gives more precise preoperative planning and margin assessment. And in pathology, it gives more reproducibility, quantification, accuracy, and efficiency. And to take home, I will really want you to know that pathological discordance is a real challenge in early breast cancer care, specifically because of the biopsy limitations. And the digital pathology will build the foundation for accessibility, collaboration, and efficiency. But AI will transform everything into a diagnostic partner, reducing the variability, enhancing the precision, and supporting disciplinary care. But I will end up by saying AI is not here to replace us, but to guide us towards more consistent, compassionate, and precise breast cancer care. That's all. Thank you for listening, and I hope you actually enjoyed.
Thank you, Arwa. I think we are all opting for a bit of digitalization, at least to start with. For ages, I have been asking for a scanner because it will, slide scanner, because it will make sharing and getting opinions, second opinions on difficult cases much more easy. Even within Khartoum, it would have made life easier. Thank you very much, Arwa. I think hopefully we will have a bit of this when we restart our services in Khartoum. We will cancel the break in the program and we'll go directly to Dr. Amna. Amna, you are here. Arwa, if you would unshare.
Okay.
Thank you. Amna, are you here? Are you with us? If Amna is not ready, we can go to Dr. Babikir.
Yes, ma'am.
Amna?
أيوة السلام عليكم.
Amna, ازيك كيفك? Can you share?
Yes, I'm there.
Can you share, please?
دقيقة. دقيقة السوشير. فين شير؟ فين شير؟ دقيقة أكبر شير.
It's at the bottom.
Yes, صحيح.
Yeah. Yes.
السلام عليكم.
Yes. Please put it in. Yes. Tamam, Amna. Let me introduce you. You can directly start. Just somebody has the giga. Amna, you are ready?
Yes.
Okay, just let me introduce you. Amna is another one of my students. She's a graduate of Ahfad University. Yes, Satik Zahir. She's a graduate of Ahfad University, and she has an interest in breast pathology, cytopathology, and education, in which she has a degree in medical education. She is working at Al Taif University. Yes,
Yes.
Amna? Yes, she's working there, and we will enjoy her topic of post-neoadjuvant therapy, pathological evaluation. A very important area, yes? Okay,
Assalamu alaikum. Our talk today is about the post-neoadjuvant therapy pathological evaluation. We're going to have an overview, what is a neoadjuvant therapy, just as an introduction and a background, and the plus pathological criteria and how to evaluate it. Generally, post-neoadjuvant pathological evaluation involved examining the surgical specimen to assess the cancer response to treatment and the quantity of the residual diseases, as well as measuring the tumor bed and evaluate lymph node involvement. Usually, this is very important because we now that the regimen we are starting with now.
No.
The evaluation is crucial for the subsequent adjuvant therapy because it has integrated with the surgical and the further working up for the patient, also as well as patient prognosis and successful of the neoadjuvant therapy itself. Usually the degree of the response depends, as we said, about the extent of the residual tumors or the size of the tumors and the involvement of the lymph node and the measurements of the tumor bed in the tissues. And in particular, a complete pathological response we need to have without residual tumor detected indicative of good response, because we have complete pathological response, and incomplete pathological response, as we will know. As a background, just as a matter of refreshment for how do neoadjuvant therapy works, usually for different tumors, not only for the breast, neoadjuvant therapy play mainly on the mechanism of, or the pathological mechanism of cell proliferations, which is abnormal. So it plays role in the, usually an antigen presenting cells, usually في L1. Usually it acts on L1, as it has mainly on the T cells, because the T cell has a major role in the pathogenesis of and the proliferations of pathogenesis of the tumors and the pathogenesis of or carcinogenesis. And usually neoadjuvant play a major role in the BDL allele antigen presenting cell L1 in specific. It has a play roles also in other factors in the microenvironment of the cell. It acts on the stress of the tumor cells. It has role in apoptosis. It has role in the hypoxic myeloid derived suppressor cells, and it has work in the proliferations and the pathogenesis process and the carcinogenesis process of the tumor itself. Controversially, some say that the chemotherapy and neoadjuvant chemotherapy specific, as in the recent studies mentioned that it has a role in the metastasis. As well, it has a role in all these cells in the carcinogenic process of the tumor cells, as it has roles, as we said, in a different processes of the carcinogenesis. But some papers say that 10%, 5 to 10% of the chemotherapy play a major role in the metastatic, but it is not so that documented and still on research. Actually, when the tumor responds for this inhibitor process or the carcinogenesis process of neoadjuvant therapy, the response for the tumor appears in two features mainly. Appears as a tumor shrinking, اللي هي بنسميها concentric shrinking, or appears like honeycomb or scattergun appearance. And these are the two processes depends for the appearance in the response of a neoadjuvant therapy and the behavior of the carcinogenesis and the tumor's pathogenesis. This is just an steps and putting a background, just a minor background about how the neoadjuvant therapy works, and this is how does it reflect pathologically. And this appears in the two responses of neoadjuvant therapy, which is a concentric shrinkage or a scattergun shrinkage. By the way, neoadjuvant therapy, it's for the breast, it's a major role, but as you know that neoadjuvant therapy, it's mainly for the carcinogenesis or for different type of tumors, not mainly the breast. So we have, before we evaluating the pathological conditions, we have the clinical response or the clinical evaluation for the neoadjuvant therapy, post-neoadjuvant therapy. And this is determined when we say that the clinical response, because it depends, when we give it the neoadjuvant therapy, it is from the oncologist mainly. They depends on the dose, depends on the duration, depends on the of the treatment, which mainly depend on the clinical presentation of the patient, which is mainly the staging of the condition, whether the tumor size, involvement of sentinel lymph nodes, or metastatic conditions, or in just a small tumor size. So we basically depend on the clinical response first, then to determine the pathological response. So the clinical response to adjuvant therapy is classified as clinical complete response, which is complete disappearance of the tumor cells, or clinical partial response, that more than 50% reduction in the greatest dimension of the tumors, or clinically positive nodes may also respond, reducing the size after neoadjuvant therapy. So clinical assessments may overestimate tumor size due to post-treatment clinical response is a predictive of outcome and related with the pathological response. So even we say that it's a complete disappearance, it's a clinical response, which when we say complete response or complete pathological response is a cutoff point. It is the end stage, it is the end point, is a cutoff point, because we examine it under microscope. So when we say pathological criteria or pathological response, it means complete pathological response which demonstrates good prognostic prediction in certain types of breast cancer, but not all the types. We have to put in our mind that neoadjuvant therapy is not responding for all types and for all criteria, and a strong positive correlation with the survival in HER2 positive, triple negative, and luminal B, HER2 negative, ER, PR positive, HER2 negative, grade 3, and breast cancer. Poor correlation with the survival usually for luminal A, ER positive, HER2 negative, and luminal B, HER2 positive, ER, PR positive, HER2 positive breast cancer. So you can have incomplete pathological response depending on the type or the classifications of the type of the breast cancer itself. That's why depending on even we want to start neoadjuvant, you have to put in your pathological evaluation of the tumor, which is the criteria and the type and the luminal classifications of the breast cancer, even before starting neoadjuvant therapy. So when we talk about the evaluation of the tumor for the pathological response of the post-neoadjuvant or a neoadjuvant treatment, we depend on the pathology, we depend on two things. We depend on the gross appearance and the microscopic appearance. When we say gross appearance, indicate degree of pathological response, which is the tumor with poor response demonstrate firm, gritty, and speculated appearance, no different from the typical untreated tumors. And we said it's not so that high percent, but still neoadjuvant therapy has no any effect in some types of the tumors, which is aggressive type or the latest stage. Response can be indicated by fibrosis or softening of the tumor, bed tumors, with partial response can be nodular, multifocal, with less well-defined borders. This is also we can determine it because before the treatment, the criteria before the treatment and the criteria after the treatment should be changed. If there is no change, it means there is no response. If there is a minor changes in some criteria like the tumor borders, fibrosis, softening of the tumors, size of the tumors, and the multifocal with less defined borders are considered as some grossly indicator for the complete response of the neoadjuvant therapy. In some cases of complete response, the tumor bed may be soft and indistinguishable from normal breast tissue. So also we need tumor mapping with radiograph, photograph, or drawing of the section gross is recommended before and after. And this is the most important thing in evaluating of a neoadjuvant therapy, the previous report before starting neoadjuvant therapy to compare and to determine which criteria it's being improving. This is some, here is this, there is no grossly, you see that the description here is this is a complete response. There is no mass tumors and there is no healing by fibrosis, you see this. But here is still the tumor mass is there. There is no changing in the borders. There is no changing in the bed tumors itself. And this is indicating no response. As we say, incomplete response depending on the previous report before starting the neoadjuvant therapy to determine the criteria and the reductions or a disappearance of them, the criteria like the borderline, like the tumor size, but still it is there with the some criteria. Type. Macroscopically, we have a different, they mention a different in different schools or different criteria or committee. When we say the multi-system, when we say the multi-system, لماذا تصار لي هي؟ A new adjuvant therapy for reporting a response for a new adjuvant therapy according to the clinical response. So as we mentioned that integration with the clinical response is mandatory. An American Joint Committee has a different classification. They put prefix of Y before the pathological criteria and YPTO donates no residual cancer, including even in situ carcinoma. And YPTIS donates residual in situ carcinoma only. And the UPT1 to 4 donates presence of residual tumors. There is a controversial point, a residual cancer burden in situ carcinoma in some not considered residual tumor, but is recommended for reporting. But in myelin pain, residual carcinoma allowed for grade 4, which is a complete response. So a presence of a carcinoma in situ, some depends on the classification or the type you are using. And for the increasing or for the continuity for the neoadjuvant therapy. But usually in the some conditions, they consider in carcinoma is not considered residual disease, but it's recommended for reporting. And this is the most important thing. And this is the negotiation point between the radiologist and pathologist and the surgeon. And actually not the surgeons, oncologist, and they consider in situ carcinoma is not considered as a residual disease. However, the pathological complete response, اللي بنسميه PCR, Most widely agreed upon definition is no residual invasive carcinoma, just depending it is an invasive type. That's why they consider in carcinoma as not a residual tumor, and we consider it as a complete response, because we are concerning about the invasive type. In both the breast and axillary lymph node, regardless of the presence of the residual ductal carcinoma in situ, and that's why I consider YPTO and YPNO. So residual tumor, we consider residual tumor when we have lymphovascular spaces or lymphovascular invasion. This is not considered as complete response. Currently, presence of an in situ carcinoma of the treatment after the absence of residual invasive in the breast and lymph node is considered constitute complete response, pathological complete response for neoadjuvant therapy. So the debate or whether ductal carcinoma in situ as a residual disease due to its association with shorter disease-free survival, but not overall the survival rate. Type. Pathological or the microscopic features determine that when we want to report that we have a complete pathological response, we are depending on the macroscopic response. Usually it's associated with fibrosis, hyalinization, lymphohistiocytic infiltrations, hemosiderin-laden macrophages, giant cell formation, and vascular proliferations. If you have all these criteria without appearance of any tumor cell, this is complete pathological complete response. And here in our pictures that determine that these arrows, these are here in fibrosis, and here are hyalinizations and hemosiderin-laden macrophages. I think it's not so that clear, but here it's appear that giant cell formation and vascular proliferation. There is a vascular proliferations, and here this is the giant cell tumors, and all these are features of complete pathological complete response. And here there is no residual tumors. There is hyalinization, fibrosis, but there is no residual tumors, and you cannot determine this is the criteria and to report. For the lymph node involvement, different scenarios could be included. Whether presence of a tumor cells with no evidence of histological treatment response, and this is incomplete or no response at all. Presence of tumor cell, histological evidence of treatment response seen, even you are, as we said, that shrinking in the size of the tumor, disappearance of the irregular borders, appearance of fibrosis and hyalinizations. So this is, we say, incomplete a pathological response. So absence of the tumor cell, histological evidence of treatment response, all of them are seen without any tumor appearance of the tumor cells, it's called complete or pathological complete response. And the absence of the tumor cell and histological evidence treatment, this is true negative nodes. The controversial also in the lymph node, we say that this is sentinel lymph nodes and the type of the lymph node involvement, the number of the lymph nodes involvement, because you have to examine all the lymph nodes you have. And the second problem or the second controversial thing is that you have already taken the lymph node before the surgery, especially in the high grade and late stage of the tumor, complete radical mastectomy with the involvement of the lymph node. So sometimes you don't have the lymph node involvement after the treatment because already have taken them out. The other thing, when we say evidence of this is in the lymph node, the same appearance you see, fibrosis, mucin pulse, histiocytic mucin pulse here, histiocytic infiltration and lymphoid depletions. This is decreasing in the size of the lymph node. Still, the same appearance will appear in the lymph node. But as we mentioned that lymph nodes are examined after treatment. Type. The incomplete response, when we say the incomplete response or residual disease, as we say that ductal carcinoma is not considered as a residual disease, but evidence of tumor response, residual tumors are present. Cutoffs for categories vary for different systems. And if there is no response, treatment associated changes are not seen in histologically. And this is incomplete or there is no response at all. So we have three. From this, we know that we have three: pathological complete response, incomplete response, and no response at all. And this no response depends, as we said, that on the the previous or the main diagnosis of the type and the degree and the stage of the pathological criteria of the tumor. This is the incomplete response. You see that small clusters of tumor cells. These are small clusters of tumor cells. Although you see that we have fibrosis and we have mucin criteria, but still the tumor response. And the most important thing, you have to differentiate by the tumor cells and between the giant cells. And this is the most striking thing. That's why breast need more expert. That's why people with the breast for that. That's why we in pathology we keep people for the pathologists for the breast are for the breast, because you have to get you to differentiate by the residual tumor cells and the giant cells, because there is incomplete response. Incomplete response, there is some criteria of the response, like fibrosis, histocytic infiltration, leading macrophages, but still the tumor cells are there. Even you don't have the tumor size at all, but still there is residual tumor. And we say that, and we return back to the same point that ductal carcinoma in situ is not considered as incomplete response, لأنه إحنا اعتمدنا على انه ما في invasion. And this is here we have some tumor cells, tumor bed. ما اعرف يمكن الصوره شويه ما واضحه، لكن هي رسام واضح لي انه انا have tumor bed still are there. Sometimes to confirm an incomplete response, because it's, as we said, it's so difficult to differentiate, we use positive stains, which are cytokeratins, which are also used in assessment of a sentinel lymph nodes in post-neoadjuvant therapy setting. And in trapped normal breast epithelium in the tumor breast is positive to cytokeratins and cytokeratins, and should not be confused for the residual tumors. So myoepithelial markers help in distinguish a normal breast epithelium and a residual in situ carcinoma from residual invasive carcinoma. And that's histocytic markers like CD68, CD163 may help distinguish a residual tumor invasive carcinoma from an infiltrating histocytes in the tumor bed. Sometimes we use an endothelial markers like CD31 and ERG may help distinguish a residual invasive carcinoma from a lymphovascular invasion, because a lymphovascular invasion is considered as incomplete response for the post-neoadjuvant therapy. So these are my references, because one of the journal, as mentioned at the beginning, that sometimes neoadjuvant therapy is considering as a playing role in the and the pathogenesis of metastasis. Although because neoadjuvant therapy, we have to stress in this point, neoadjuvant therapy works as in the microenvironment of the tumor and in the carcinogenesis process of the tumor. So it has no play major role in the in the vascular invasion in the endothelial cells. And that's why we said that 5 to 10% neoadjuvant therapy may play a role in the metastatic condition. And this is under research, but usually, generally speaking, and as we mentioned that it's not, we have to strict to some points that we must have the previous report before starting the neoadjuvant therapy in evaluating the post-adjuvant new cell pathological pathological evaluation post neoadjuvant therapy. And we have to differentiate. The main striking thing is the incomplete pathological response, because we have some criteria of the pathological response and some criteria of the residual tumor. So we prefer to use distinguish positive stains to distinguish between the types of the cells. And that is my talk for today. Hope it was very focusing and to the point without distracting to some.
Thank you, Amna.
Else.
No, an enjoyable lecture as usual. Amna, thank you so much.
Thank you, Dr. Nadia. This is we get from your experience, and Dr. Salwa.
عفوا عفوا.
We enjoy
your lectures.
في ولا طلعت؟
I think she's available.
Thank you so much. كيف أخبارك؟ كويسة؟
الحمد لله.
Nice to hear from you now.
Thank you.
Thank you.
Amna, can you unshare so that Babikir can start?
I don't have more to add. And thank you for listening.
Thank you very much. Can you unshare your talk?
Okay.
Your presentation.
Okay, I will. Thank you.
Okay, thank you. Thank you so much, Amna.
Thank you.
Babikir, are you available?
Yes, I am. Assalamu alaikum.
Babikir, ازيك?
كيف الحال?
Alhamdulillah, alhamdulillah. You can share your talk.
Okay.
Tamam. I can see it. And now you can do slide share or present. Yes, mashallah.
Okay, assalamu alaikum.
You are ready? Shall I introduce you?
Yes, please.
I graduated with Babikir. We were in the same group. Shall I say the year? أنا ما عندي مشكلة يا Babikir. We graduated in
the MD, isn't it?
It's the MD, yes, 1994.
Yeah.
And Babikir has worked in many hospitals. I cannot relate all your CV, mashallah, Babikir. You, especially in England, of course, in Sudan, and then in England, and I see in Saudi Arabia. He's a senior histopathologist with an interest in cytology and research, and he will be presenting pathological aspects of microclassification from the pathological side, because yesterday we heard a lot about microclassifications in radiology. Tfaddal, Babikir.
Thank you very much, Nadia, and thank you for your respected forum. I hope, inshallah, the next meeting will be physical in Khartoum, inshallah.
Inshallah, inshallah.
I'm going to talk about I'm going to talk about microcalcification from pathological point of view, and it's very important specimen when we get a core biopsy for microcalcification. It's a challenge for pathologists, and we need to get the best of that specimen. My talk will be mainly, I hope will be beneficial for everyone, but mainly I would love if it's going to benefit the histopathologists in their practice on how to deal with microcalcification. So the definition of microcalcification is presence of calcium deposits which measure less than 0.5 millimeter in breast tissue, and which is also visible on mammographic imaging. And the calcification is a common finding in mammograms and can represent both benign and malignant conditions. So microcalcification doesn't mean automatically this is a malignant condition. And about 42% of non-palpable cancers can present with microcalcification. Histologically and chemically, we have two types of microcalcification in regard to biochemical composition. Type 1, which are calcium oxalate. These are not very easy to be seen microscopically, unless if you use polarized light. And type 2 is the commonest form of microcalcification, which is the calcium phosphate. As microcalcification is there, macrocalcification is also there, and it is less significant in the settings of cancer, and it is the most prevalent calcification type in breast tissue. Typically it is benign, but and may not in most of cases need follow-up by imaging. On the other hand, microcalcifications appears as small white spots. The spots may be randomly scattered or maybe may appear in groups or specks. And also microcalcifications as macrocalcification are usually benign, but they are more likely to signify cancer than macrocalcifications. So we've got a lot of benign microcalcification. It doesn't mean automatically that if there is microcalcification, this is malignant. We have a lot of benign conditions that we will come to later that could present microscopically with a microcalcification. So the pathophysiology of calcification is from mineral, thought to arise from mineral depositions, and they can result from various physiologic processes. And this is normally the benign macrocalcification, which I said is very common. Could be secretory, inflammatory, senescence, that means after 50 years of age, traumatic injury, fat necrosis, etc. All these are causes of benign microcalcification. The dystrophic calcification in breast tissue is a passive phenomenon, and there is a lot of pathophysiology in regard to this, which I don't want to get into it. The microcalcification can occur at any age, but is common in older women, as I said, after 50. Women with history of breast cancer also may have higher likelihood of developing microcalcifications. And the reverse is true. Women with microcalcifications have a higher risk of developing breast cancer. And there is a strong association between presence of calcification and HER2 overexpression. As I said previously, there is physiological microcalcification, and there are some benign reasons of microcalcification, like breast injury. Pendulous breasts tend to have fat necrosis, and the necrotic tissue will calcify. Also, breast cyst can have calcification, breast infections, and sometimes the calcification in the arteries, which appear linear in X-rays, and also in some benign lumps like fibroadenomas and ductictasia, previous breast surgery, previous breast cancer treatment in the scars, etc. And here are two types of calcification. One is in a dilated duct on the left. It's not very clear because this is a calcium oxalate. It doesn't show the pink bluish color on the right, which is seen within an area of fat necrosis. All these white foamy cells are macrophages. On the left and on the right, also, there is calcification within benign lesions. The lesion on the left has got some flat atypia, and the lesion on the right, most or all of the pathologists would recognize that this is a fibroadenoma. So if we come to the clinical significance of microcalcification, it's always it is asymptomatic, unless if it is accompanied by other symptoms. And microcalcifications are identified during mammograms and classified on mammogram. I'm sure that you have heard a lot of this using BIRATS 1026. And the presence of microcalcifications on mammography led to the detection of breast tumors, which are as small as 1 to 2 millimeters. I myself have seen one tumor previously. It's 2 millimeters, and that has to be in a breast screening program because these are normally asymptomatic and very early stage of cancer. If you are seeing cases which are within a breast screening program, then you will get used to see very small cancers, 5 millimeters, 2 millimeters, 3 millimeters, etc. The microcalcifications are present in about 50% of carcinomas compared to 20% in benign breast disease. And only 20% of suspicious microcalcifications are actually part of a malignant process. So the diagnosis of microcalcification, as I said, the whole story starts with the mammography. Better if it is a screening breast program rather than just symptomatic patients, because most of symptomatic patients will present with very obvious tumors, maybe masses, etc. You will not see a lot of microcalcification or malignant microcalcifications in the routine clinical setup. The radiological findings and the history are all obviously should be there. There is a triple assessment which we followed in UK, that is clinical and radiological and pathological, and they have all grades 1 to 5 as in the TIRAD, which is now becoming very popular. The core biopsy is frequently performed if there are microcalcifications. And in UK, if there is a microcalcification, normally they take X-ray for the cassettes themselves to make sure that the microcalcifications is sampled within the core biopsies that are submitted for pathological examinations. And pathologically, we need to compare and correlate the pathological finding with the imaging finding, especially in lumpectomies or wide local excisions or mastectomies. We get in pathology with the request, we get also X-ray of the patients. Now, the X-ray is available widely on the PACS system, but in the past we used to have a copy of mammography attached to the request. And what I'm going to say now is very important, that if the initial levels do not show microcalcification, please do generous deeper levels. And if these are not seen, and the biopsy is not stereotactic and not associated with blocks stating whether there is calcification or not, then there are two options: whether the biopsy has missed the lesion or whether the calcium source needs polarized light. So you have to use the polarizer of your microscope to see whether these are calcium oxalates or not. In radiology, I think I'm not going to get into details of that because I'm sure you have been told a lot of this by our radiologist colleagues. And this is the famous BIRAD system. It is now also in thyroid, called TIRAD, and I'm sure it's going to be everywhere. Right. The calcification could be present anywhere in the breast, throughout the breast tissue, and most commonly within the mammary ducts and the surrounding fibroglandular tissue. And that includes stroma, vessels, skin. Under the microscope, as I said, there are two types of microclassifications based on biochemical composition, and the type 1, which is the calcium oxalate, and type 2, which is the calcium phosphate. Type 1, which is the calcium oxalate, is less common, and these are crystals that do not bind with hematoxylin stain, and they appear under the microscope as clear refractile structures. They are best visualized under polarized light, as I said previously, and the condenser should be flipped down for optimal observation. They are predominantly found, and that is, thank God, that they are found mainly in benign cysts. So if you don't have a polarizer and you miss them, then most likely they are related to benign procedures. And they are often demonstrated histological features of apocrine cells, which are having some calcification. Can be associated as well with lobular carcinoma, and that is a bit scary because lobular carcinoma sometimes can be missed. The lobular carcinoma cells are very uniform and very sneaky, and they can look in low power like just fibrous tissue and very subtle. So when they are associated with invisible calcium oxalate crystal, that was making a very dangerous combination, and the polarizer is very important in this situation. They are also rarely seen in association with an invasive carcinoma. On the left, this is the previous picture. I'm sure some of you have recognized that. This is a dilated duct. On the left of it, there is a lump of a bulky, irregular form of structures which look like white opaque, and these are the oxalate crystals. On the right, this is when you use the polarizer, they will become very clear, shiny, like the stars on a dark night. The other form of calcium salts that we come across in histopathology is the type 2 calcium phosphate. And as I said, these are commoner, and they manifest as purple, blue, samoma-like aggregates, either solitary or clustered, when these are stained with our H&E stain. They can also be both observed in benign and malignant lesions. They are commonly associated with pre-malignant and malignant lesions. On the left, this is a DCIS, and on the right, this is an atypical ductal hyperplasia with some apocrine changes, but it's very difficult to see from this resolution and power. So these are the globule or the globular structure at the top, which has got a pinkish red granular material within the center or the lumen of it, is a comedonecrotic DCIS, and the pink reddish material is necrosis. The calcification is a bit below that, and it shows some fractured calcium, which looks a bit darker below the necrotic area in the middle. And on the left, it's not very clear, but it shows one of the ducts there, or maybe two ducts, one at maybe 11 o'clock and one exactly in the center of the field. So if, and this is again, I'm going to repeat this again, if a mammogram revealed the presence of microcalcifications, then pathologists should do diligent efforts to locate this microcalcification. And if this has to be documented in histology report along with any associated lesions. And the calcification could be either ductal or lobular. And in ductal setup, it occurs in columnar cell change or flat epithelial atypia. I have shown one of them here, or atypical ductal hyperplasia. I've shown another one. And also in DCIS, which I have shown an invasive ductal carcinoma. The lobular calcification occurs in cystic breast disease and in sclerosing adenosis, atypical lobular hyperplasia, ALH, lobular carcinoma in situ, and invasive lobular carcinoma. And this actually, the message that I want pathologists to take home is when you are looking for microcalcification is step one, examine the H&E stain slide meticulously for microcalcifications. Step two, if no microcalcification appear on H&E, utilize polarized light microscopy to detect calcium oxalate clusters. And step three, consider cutting deeper levels of the H&E slice for further evaluation of microcalcification, especially if this has been confirmed by radiology and they have X-rayed the cassettes for you. Step four, you have to utilize X-ray imaging. You could do the other way around, send the blocks for X-ray imaging to check whether they have got calcification or not. And step five, consult with the radiologist to confirm that the lesion has been biopsied. And in some setup, when it is a stereotactic sampling, most likely that's very sensitive. But in setup where people, they just do unassisted biopsies, that you need to talk to the radiologist. And I think in the box now, there could be a video showing the insertion of the needle and the passage of the needle and confirmation of sampling the calcification. So we talked earlier about dystrophic calcification, which could be a differential diagnosis of microcalcification, which is pathological or benign, and also the vascular calcification, and that normally is parallel streaks and distributing along the path of a blood vessel. These are my references. And these are picture of samoma bodies from a meningioma. And these are you. Thank you very much. I hope you enjoyed it.
Thank you, Babike. It is an area where really we need the cooperation as usual in interpreting our specimens. We need the cooperation of all the modules involved in diagnosis.
Dr. Nadia, can I comment or can I ask?
تفضلي.
السلام عليكم ورحمة الله. Dr. Babikir, mashallah, very nice and to the point presentation, amazing. But my point, yesterday I mentioned one point regarding new literature about the DB, the primary origin of breast cancers, okay? And the relations to the calcifications, ductal and lobular type. What do you think about this? Do you have any idea about these new classifications? This is one point. And I would like to say that, yes, regarding microcalcifications and the amorphous maybe on radiology is not corresponding to what is called amorphous in pathology. Do you agree about that? And can you just explain it to us pathologically?
Thank you very much, Dr. Rabab. Actually, I missed your presentation yesterday, and I need to read about that. The first question, I'm not. I haven't been there. If you send me the paper, we could exchange some views on that in the group. But the calcification, I think, with all radiologists that we work with, they were very precise. I mean, normally this is more cluster, the specs, they call it, the group, the clusters. These are the most one that they are worried about. And when we go to the MDT and they tell us that there are calcification, we have to work hard on that to get the calcification, because sometimes, as I said, it could be benign, it could be there, but benign. There is another issue which I haven't talked about, and also that is mainly directed towards pathology. Sometimes calcification itself is very difficult to be sure of, especially with, I mean, if the facilities are not that good and the setting is not good. Sometimes there will be like bluish secretions in the ducts and glands, and that might confuse us sometimes, even experienced pathologists. So it's very important that you get the calcification which looks like the classical one that I have described, and whether that the granular, I think the amorphous could be more related with necrosis, etc., rather than the microcalcification, which we see normally in the pre-malignant and malignant breast conditions. If it is very extensive, if it is all over the place, then there might be a dystrophic calcification process, which is not exactly or worrying like the microcalcification that is picked within small areas of the breast. So that's all what I could say about this. But if you have a specific thing about the amorphous, we don't normally amorphous, we use it in our description in cytology mainly, and that when there is a lot of proteins and exudates, etc. So we'll see some amorphous materials that could be within the tissue or within the cytology. But do you use amorphous?
It can be, yeah. When you talk about amorphous, you don't mean it is not. What I mean that when you talk about amorphous calcification in pathology, it doesn't mean that corresponding to the amorphous calcification we have seen in mammography. This is the point what I would like to emphasize. And regarding mammography, we have typical benign, 9 typical benign calcifications. This is when it is not typical, okay, then we call it suspicious. So regarding suspicious, we have 4 types of suspicious. We have amorphous, pleomorphic, coarse heterogeneous, and linear branching, 4 types of calcifications. This is regarding the morphology. While amorphous calcifications is more suspicious than coarse heterogeneous calcification, but it is associated with low-grade DCIS. But the coarse heterogeneous, it is more or less the same as fine polymorphic. The difference is only size. The fine polymorphic is less than 0.5, while coarse heterogeneous is 0.5 to 1 millimeter. It's still considered to be mixture of calcifications or of varying density, size, and morphology, shape. And they call it like broken glass. This is the coarse heterogeneous, while fine polymorphic calcification, they call it as crushed stone, okay, a little bit finer. Both are associated with higher grade of DCIS, about 2 or 3, grade 2 or 3, more than amorphous. Although when we talk about the positive predictive value for malignancy, the least is coarse heterogeneous, is about 15 only, while the amorphous is 20. And the fine polymorphic is about 30%. The three of them are by RAD4B, but with different different level of suspicions, though within the same group. The highest one is polymorphic, and the polymorphic is usually associated with aggressive type of cancer, commonly associated with aggressive type of cancer, HER2 positive, and with triple negative. And because it is the commonest mammographic type of presentations, okay, of DCIS, and it's also it represents about near 50% of DCIS presented on mammography as fine polymorphic calcification, and it is commonly more common presenting in a segmental distribution. That is why they consider it most of the time as ductal origin. But regarding the distribution of calcification, we have either, if it is confined to 1 centimeter or up to 2 centimeters, okay, 5 particles within 1 centimeter or more particles within 2 centimeters, we call it as a grouped, or previously called as clustered calcifications. Okay, and this, when it is more compact and more number of calcification, the more suspicious. But early on, it might be few calcification, just about 5, and dispersed. And here we'll be in a dilemma to request to recommend biopsy or not. And as you mentioned, it can be seen, all these type of calcification can be associated with benign as well as malignant calcification, with exceptions for the linear type, which has the very high grade seen in up to 70%, represent 70% having positive predictive value, okay, associated with DCIS, especially when it is typical. Typical, that means it is irregular, it is fragmented, it is pleomorphic of the varying density, size, and haphazard, and that things, then it is highly suggestive of DCIS, even if it is not associated with any underlying other associated mass or asymmetry or distortion, or as a sole sign, it is by RAD4C, and it has to be biopsied. Because extremely rare, the secretory type of calcifications, the counterpart, benign calcification, is usually seen as a little bit longer and smooth and of uniform density. This is regarding the typal morphology. As I mentioned, distributions, group, it is, if I have seen any type of calcification in a group, it will be by RAD4B, about 30% probability of being malignant. And even less, a little bit less, but still برضو it is same by RAD4B is regional. When it is more than 2, I have is spanning in more than 2 millimeter, more than 2 centimeter, I mean, sorry. Okay, these are 2 by RAD2. When the distribution following a ductal in a linear or segmental, then it will have higher probability. Any type, even round calcification, if it's seen in segmental or linear, then this is per se, regarding only the distribution, it will be by RAD4C, and we have to proceed for biopsy. This is regarding the distribution and the morphology of suspicious calcification on mammography. But regarding the origins of cancer, the current or the recent research, they divided the cancer, or classified the cancer by site of origin, the type 1 أو the AABs, اللي هو acinar adenocarcinoma of the breast arising from terminal duct lobular unit representing the majority 75% of the cancer, having a little bit better prognosis than the ductal type, and the in situ component of which called CIS. They said since it is not related to the ductal system, they have to call it a CIS rather than DCIS, while 20% of cancer found to be arising from the main lactiferous duct. Okay, and this it is usually found to be grade 3 DCIS and aggressive type of cancers, and associated with ductal type of calcifications and associated with ductogenesis and so forth. And here the in situ component of which they have to call it as a DCIS. Thank you.
Okay, thank you very much for this very
Thank you
important
very
topic.
much.
Thanks a lot.
Thank you very much. This was very interesting. And you touched on it yesterday in your lecture. I think it
Yes.
needs a lecture by itself so that we learn the details slowly. Thank you, Rabab.
Yesterday الكلام كان كتير فدخل كله في بعض.
Hi. Babikir, thank you very much for your talk. And please, can you unshare so that we ask for the last speaker in the pathology session?
Okay. Is it unshared now?
No, not yet.
Right. I think the easiest thing is to close it, maybe.
Okay.
Right. So
I
can't
think go
see the unshare
to
button.
the green.
To the
Okay.
green arrow, yes.
Green arrow.
Yes.
Down in the there is a green arrow. Share. There is word share.
We want to
couldn't
unshare.
Right, just a moment. There is a green arrow here which says share.
Press on it, you'll find unshare. When you press on it, you'll find unshare.
I think you should take the cursor upstairs. Yes.
Here?
Very high up in the monitor, and then you will find stop sharing. You will find it.
Stop sharing. Okay,
Go
yeah,
up.
that's it. Yeah.
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 Thank you.
Perfect. Thank you.
Tamam. Thank you very much, Babikir.
Okay. Well,
Prof. Afaf. Our next and last speaker is Professor Afaf. Are you with us? Yes, I can see you are starting to chair.
Maybe you can unmute her, yeah, Dr. Nadia.
I will have to find it. It's not working. Dr. Afaf, Prof. Afaf. Yes. I have no idea. Just a second. I will try to get her. I cannot unmute.
Yeah, Prof.
Prof. Afaf.
Go down بالكيرسر بتاع الماوس بتاعك down down down, then the panel will appear for you and you will see the mic. Just click on it, it will unmute. Go down with your cursor. I can see your cursor now. No, not the presentation. If you hear me, yes, down, down. No, down in the screen. Yes. Yeah. A ribbon will appear for you for the Zoom. Maybe down or up.
أعتقد لما تكون مشيرة ما بتقدر تعمل من تحت، فخليها تعمل ستوب شير وبعدين تفتح المايك حتى بعدين تعمل شير تاني.
اوكي خلاص.
Why can't I unmute her like I've been doing it, except in her case now?
Maybe because she already shared her name.
Now it's open. I can.
Yeah, okay.
Okay, now start sharing again.
I can't see it.
Not yet. We don't see it yet as well.
Well, it is your only.
We still cannot see your screen like before.
Isn't there an IT person here? Well, I can't see it either. Unstable connection.
Dr. Afaf, you need to share again because you stopped sharing.
Try again.
No, I haven't. I'm still sharing. Okay, stop sharing. And then new share. When I share it, I get Nadia Dawi.
Hey, why?
Yeah, because
okay.
What happened?
Dr. Afaf, you have to open your presentation.
I have opened it now.
Okay,
can you see
then
it?
when you press on
can you see it now?
No, we cannot.
Allah, I can see it.
Yes, you can see it in your screen. So now you have to share it and choose your presentation when a panel opens.
Yeah, here.
Yes, and then choose your presentation itself and
here it is.
Click on start sharing. Yes, so it will come soon.
You are screen sharing, but where is the presentation?
Because you shared.
دكتورة
You
انت عملتي
shared
share السكرين.
the whole screen.
نعم.
You don't need to share. You shared the whole screen of your laptop. عملتي share whole screen. You need to share your presentation only.
That's what am I doing? Okay. طيب, let us. Here is the presentation and share.
Yes.
Now I get Arwa.
Yeah, because I'm talking, but it will come. It will come.
Yeah. Go on yourself and see whether you can get a thing.
Okay, can you go with your cursor
Okay, I'll
down?
stop. Yeah.
Okay, that's it.
Yes.
Can you see it now?
Now
Yeah,
make the
I
slide.
can see it now. Can you see it?
Yes,
Yes,
we
we
can.
can see it now.
Yeah, fine. Okay. I'm sorry about that. Yeah.
No,
Okay.
no problem.
Okay.
We have
Yeah.
finally started.
Have you?
Yeah, all right.
Yes.
Yeah. Hello. Thank you very much, and hello all. And I would like to particularly welcome Mr. Isa Azraq and Mr. Isa Nail. He's my colleague and consultant breast surgeon in England. And he's also a co-director with me in the Sudan Doctors for Human Rights organization. We'll talk a little about it at the end, in the end, because it's relevant to the talk. So I am sorry, after the so rosy and very beautiful earlier presentations, I am really going to depress you, but it's actually a fact of life. And that's what's happening now, but we have to think positive and see what...
And we have to handle it.
Yes, yeah. What can we do with what we have? Okay. So,
Prof. Afaf, just before you start, could you just click on your screen? You have something at the bottom, because it's will go into every slide. Yes. Thank you.
Okay.
That's lovely.
Yeah.
You are so welcome.
Yeah.
Totally.
Okay. Thank you very much. And we all know that unfortunately we are living a bad era of our time. Conflicts are ongoing worldwide, and they will still be ongoing. So far, there are more than 130 reported so far from east to west. Namely, now what we are now living is the Sudan, Ukraine, Yemen, Palestine hopefully is coming to a halt. I hope we shall follow soon. And for the Sudan, the war reflects the worst humanitarian crisis in history. And that's really by testimony of all, by the United Nations and everybody. But still, we need to treat patients and look our patients and offer the best that we can. Okay, this is no news to you. Probably it may be my house, your neighbor's house, our hospitals, anything. And actually the metaphor here that it's not only the ongoing war, but our health services are going up in smoke. And particularly the women have been affected. They have been on the move, looking for food, fetching for water, and fending for fodder, for fire, for food, and for everyday life. And they are just from place to place, and there is no settlement. Okay, and according to the latest statistics, the war has seen there is severe deterioration of women's health, and it's widespread. There is gender-based violence. There is shortages of essential medicine and supplies, and inadequate access to reproductive and maternal services. There is malnutrition, and now we have infectious diseases. Malaria and dengue fever are rife. It's not to underestimate also the effect of cholera. The lack of water, the lack of food, the lack of sanitation, in addition to complications due to childbirth and lack of midwives. To talk about breast cancer and breast cancer screening is a luxury, but this is the women's right. We have to consider all aspects of their health, and this is what concerns us for the moment. the current health situation, you probably know better, especially those still living in Sudan, that about 80, probably more, of our hospitals are non-functioning or completely destroyed. Universities and medical colleges are closed. And our pride, the National Health Laboratory in Khartoum, which was actually the first in Africa, maybe is non-functioning, and the services are moved to Port Sudan. I don't know about breast care clinics and about the imaging facilities before, and of course, needless to say now, and I suspect they are non-existent. This I got from a paper by an Arab, Al Ibrahim. He was comparing the crisis and effect of their effect on the health situation in the current countries that I mentioned. And he mentioned actually rightfully that when Sudan saw the establishment of the first cancer center and the first cancer registry in Africa from the 60s, now we have none. We have mainly the cancer services, mainly in the Khartoum Oncology Hospital, the National Cancer Institute, Tumor and Therapy Center Research in Shendi, and in Marawi. These are all new to me. Of course, probably they are recently been established. Otherwise, everything else is private. We, of course, what concerns us is the governmental services. And in Sudan, there is a rising number of new cancer cases, and it is not a surprise. In 2020, according to this paper, the WHO estimated the number of new cancer cases are 27,380 or 400, almost 28,000, both sexes, male and female, as compares to 2010. Where they were a little bit less than 7,000. Okay, now the challenges of health provision in this situation. Actually, people face a challenge of security, available funds, and I suspect there are none, governmental. Probably the reliability will be mainly on human rights organizations or international organizations and the WHO and other. The infrastructure, lack or probably non-existent workforce in many places. Our pathologists are spread all over the world and probably getting de-skilled by the day. Our technical force is also widely dispersed and probably are seeking other sorts of employment. The supply chain, where are our consumables going to come from? Essentially, the formalin, just simply to fix our tissues whenever we have them. This is rightly said by James Murphy that working without pathology services means taking an educated guess about what is wrong. It is just a leap in the dark. So let's see what we can do with the very little that we have. What we require now, we need really, and this is more than any time else, we really need high quality. We are going back to morphology because this is the basic of histopathology and is the basic for any future test that we are going to undertake. If we can get reliable immunohistochemistry, essentially for breast cancer, of course, we are talking, if we got hormone receptors, that is enough. And this is really going to be great. And you know that now estrogen receptors, progesterone receptors, together with Ki are surrogate markers for oncotype DX and predictability of the behavior of the tumor that is diagnosed. We have to have robust quality assurance and continuous training. Maybe robust quality assurance will be a challenge, but we may be able to have some form of continuous training that we will discuss later. Most important, we need really good archiving of our blocks. Whatever very good blocks that we have taken, we need to store them in a secure place for future tests when the life gets better and we return back to normality. For example, we can undertake HER2 testing on these archive blocks, and we can get cytogenetics if we really get more prosperous. And this is not really impossible. For archiving of the blocks, if we can't now with our current situation, now there are companies, and you can really invite or really encourage business people or companies to supply archiving places. Here, we are archiving our all places from Hull in a special company. There are companies whose specialty that is to preserve the blocks and slides in the best possible way. And of course, all this is monitored. So that's a possibility. Okay. Our formalin supply. Formalin is not difficult. And I'm sure we can have access to formalin now and in Sudan. We should have a tissue processor, even the old one, if we can really refurbish those that are left or whatever are there, we can use them, and we can really concentrate these in certain centers which we can guard and monitor. We should stick to high quality staining protocols that are reproducible and have quality assurance, quality control, internal, external, rigorous, especially in this situation. And this is not difficult. We have to start capacity building by continuous training and task shifting. You may be trained in one thing, you can really be trained in another thing, especially for our laboratory staff. Our local pathologists, how can we empower them? Poor things, they have no salaries, they have no access to anything. So at least we can keep them in training. Our laboratory scientists alike, our technical staff. And this all we can do through training courses, virtual. Hopefully there is a robust internet and power supply. We can do workshop, webinars like the one you are doing now, which is really excellent. And we can really produce teaching modules. What is possible now? How can we reach out to patients? Health education should continue. How can we reach them? Everybody now, or almost everybody, has a mobile phone. If there are no TV or radio services, we can arrange with local mobile providers and send messages like we get now from the police, from the local council regarding anything, just an education about now for ladies, breast examination, look for any lump. There may be ladies who are breastfeeding, getting abscesses, lumps here and there. At least, or encourage them, reassure them that really early cancer can be managed, can be treatable, and so on, what to do. And then, of course, we can have properly prepared histology specimen, archive logs and reports, as I said. And then we must have a good communication with surgeons, oncologists, breast care nurses, and most importantly, patients. All this we can really do through the simplest method, simply through mobile or WhatsApp groups. And in this way, we can establish centers of excellences in each big city. Let's just concentrate on the largest lab that is really now in shape. And I'm sure we can get help from outside, from international institutions, from the WHO, whatever. At least we have to do our homework and start somewhere. Okay? And then these are the teaching portals.
in the RC Royal College of Pathology website, there is a pathology portal where there are conferences and CPD events. These are happening all the time. And there are educational sessions on gross examination of various systems, not the least, of course, the breast, how to do a frozen section. In Ghana, they have a video lecture series which are regular, and they are posted in the Royal College website, and these are free. Everybody can access. We in the Sudanese Pathologist Diaspora Group, we are doing the list, but we try to do our best by inviting actually experts or just keeping people up to date with things. There are the WHO reference series, which can be available free of charge online. And actually, not to mention forget to mention the RC PASS Royal College Pathologist Reporting Guidelines. And this you can tailor to your needs. You don't have to be very comprehensive about the reporting guidelines, as much as you can really shorten it to your needs and to what the surgeon and oncologist need at the time being. Okay, now I mentioned the Sudan Doctors for Human Rights. As I mentioned, Isa and I are co-directors, and this is a UK-based organization. We have partners, and we have really influential partners who can help. We have liaison with several international organizations. And if we get a list or a statement of needs, we can try to help in some way. We are now helping a few hospitals, especially in the West. We have supported actually financially, and some of the hospitals in Khartoum, like Al No, and Isa can remind me if I have forgotten anything. So contact us, let us know, ask for help, and we will do what we can. We can fundraise, and we can cooperate with local partners, as I said. There is a group who's called LabVine. Maybe somebody of you have heard about. This is a South African-based group who is mainly actually does courses in development, and also it runs management programs. I did an excellent management course with them, and since then I became sort of a friend of theirs. So this is their website, and they do have several free online courses on every aspect of the laboratory service. So you can join their courses, and I can raise this and actually get your voice to them and see how can they help you, at least in keeping up to date in training, in learning, and so on. And so it is not impossible, and there is something that we can do, and something is better than nothing. Let's hope that this war stops soon and we go back to normal. Thank you very much.
Thank you, Dr. Afa, for raising this issue for this tragedy in Sudan. We hope that everything went well, and hopefully, and within a short time, everything can, at least the minimum required, can be available there.
We definitely hope that. Thank you, Prof. Afaf, for this. It looks very dreary, but you gave us hope. I should say that today I got the news that, because we are talking about governmental establishments, that the lab in Port Sudan, which is the so-called new capital, does not have a histopathologist. It has a junior histopathologist that does the grossing, but there is no histopathologist in Port Sudan. We are not even talking of a remote area. We are talking about Port Sudan.
Actually, Nadia, the problem is that pathologists are everywhere, مشتتين في العالم كلهم. look at us كلنا هسه كل واحد في حتة، ما في السودان قاعدين.
Yes, but
أيوة.
even although we have pathologists working in Sudan, Port Sudan, which is now the area for the health laboratory, does not have a pathologist. And it is
the problem is how to settle in a city.
Although she is a head of pathology, to reach out, she reached out, but it was difficult to do. So we have multiple problems at different levels.
طبعا مشاكل كثيرة في إنه to settle in a city ما يعني where you haven't been before, financially you cannot. بالذات بورسودان غالية، تعتبر من المدن الغالية.
Thank you very much, Dr. Afaf. And if there are no questions or comments,
thank you, Nadia. But I am not a prof. I am not an academic. Okay. Thank you all.
Victor and Nadia, may I just comment? Victor and Nadia, may I comment, please? Can you hear me, people?
Yes, I can hear you.
I just wanted to comment about Port Sudan because I have a personal experience there. Actually, formalin was an issue because we ran out of formalin and it was really very difficult to bring anything outside of the Sudan. And the other issue was the paraffin. We had a big problem providing good quality paraffin, and actually we actually were forced to use bad type of paraffin and bad type of cassettes. The cassettes open inside the processor machine. The things mix up, and we have robustly or yani working group there in the lab. We sat all together and we tried to sort out which specimen is which. And really, we were very hard to produce very little results. And we tried actually our best to use telepathology. And we actually managed to do that for like 2 months. But then we actually couldn't because of the safety issues, because even the good registrars who used to prepare everything, the grossing, the slides, and put them on the scanning electron microscope, not the light microscope, actually the digital one, and send the photos to me where they found it difficult to stay because of the safety issues. They can't stay even in Port Sudan. And it's a problem everywhere, actually, because people try to settle in Gadarif, and it became like hell. And then in Merawi, and also something happened there. And you can't tell anyone to actually jeopardize the safety of their families, not to say themselves. يعني ما أعرف, it was really miserable, and I hope everything will alleviate soon, and we are very ready, very, very ready to go back and lend our hands to restore. And I don't want to restore, actually, because we were actually in a miserable condition. We really want to start very high and restart from a very high point, because Sudanese people deserve the best. Thank you, and thank you all. And I'd like to thank everyone, and especially Dr. Rabab. Thank you for everything that you do. You really faster you really push up high. And thank you for
Thank you for all of you. يعني very impressive presentation, the pathology lectures. يعني we enjoy it too much, and I'm يعني proud of you, and I'm so happy that يعني we joined together, and I hope that when we put our hands together, we can change and we can improve a lot, inshallah.
Inshallah. Thank you so much for this platform and to show the immense conditions that we work under even before the war, and to make it possible that eventually when we start, as Arwal said, that we can start and establish a much better system that will serve a lot of people in Sudan. Thank you, Rabab, and thank your organization for allowing this to happen, these presentations.
Thank you, Rabab, and thank you all.
Thank you.
I can see that one of my colleagues, younger colleagues, Jihan. Are you still here? السلام عليكم جيهان, ازيك؟
Still here? كانت فيه.
How about another one of my colleagues, Hiyam? No.
Hiyam probably left, but I'll convey your message. Thank you all. Thank you very much.
Yes, okay.
Yes.
Thank you so much. And
Okay.
you didn't give me a chance to introduce you, but I think everybody.
No, never mind. Never mind.
You are one of my mentors.
Okay, no problem at all. Yeah.
Thank you.
Okay,
Thank you
all
very
the
much.
best to you all. Yeah. Okay. Thanks.
Thank
Bye.
you very much all for your presentation. We close this session, and after a break, we'll be coming back for surgery. Rabab, can you let me know? It's early time, but maybe the surgery want to start earlier?
Can we give this hand for surgeons to comment? Because so many of the surgeons were attending actually.
Yes, if they would like to start earlier.
Yeah.
Dr. Omar, I think I saw
to comment on
let us ask
Gladly you can comment. If anybody wants to comment, you are أهلا. دكتور عمر, ازيك؟ كيفك؟
ايوه, كيف اخباركم؟
تمام الحمد لله, تفضل.
الحمد لله. Thank you, very nice and useful session as usual from the pathology يعني colleagues. طبعا I cannot speak for the rest of the surgeons. ف يعني تخلي الناس ياخذوا break. We can start earlier than the time proposed if the other people agree.
Yes, it is.
I think
not yet 1 o'clock.
Yeah, we can take 10-minute breaks, okay?
15.
And contact Dr. Tamadur to start the session of
Rabab, 15.
15 minutes, okay.
عشان الناس يصلوا
It's okay, no problem. No problem. 15 minutes break, and then Dr. Tamadur will she's going to take the session of surgery inshallah.
مرحب دكتور عمر.
عليكم السلام.
كيف اخبارك؟ ان شاء الله تمام.
اهلا دكتور سلوى, ازيك؟
احوالك؟ ان شاء الله الحمد لله بخير.
الحمد لله.
long time.
اي والله انت ان شاء الله كويسه؟
الحمد لله بخير.
الحمد لله. احنا ما مشينا بعيد من مصر دي عشان
ايوه انت بعيد.
ايوه. لا ان شاء الله بتكلم معاك, بضرب ليكي.
ان شاء الله.
الله يسلم على الجميع.
يبارك فيك. الله يسلمك.
تسلمي, شكرا.
Okay, so we can close this session, and I say that 15 minutes would be 5 minutes past 1 o'clock midday, and see you then again soon.
Thank you, Nadia.
Thank you.
So we'll start on time at 1 o'clock, yes?
Yes,
1-5.
please. 1-5
no.
بالسرعة ال 15.
Okay, okay.
I think 20 minutes will be more convenient because, you know, people are in here since the early morning.
Okay. I think by the time we start, it will be 20 minutes. Thank you, everybody. Thank you, Sarah, for start for pathology.
Tamadur said they are going to start at when?
Okay, fine.
Okay.
Fine. Thank you very much. Bye-bye, everybody. نتقابل في الخرطوم.
She agreed. She agreed for 15 minutes. Sorry for that.
Okay. No,
Okay.
so it is
We'll take break.
1:05.
We'll take yeah. After 15 minutes from now.
Tamam.
Okay.
Okay. Bye-bye.
السلام عليكم.
عليكم السلام ورحمة الله.
مرحبا مستر عمر، كيف الأحوال؟
مرحبا ست مادو، كيف أخبارك؟
تسلم يا رب.
ست مادو. الحمد
ما
لله.
عارفة وين باقي التيم؟ لسه في بريك.
نديها لحد 10 كده عشان
ممكن أيوة.
another
عارف
minute.
برضه في جروب.
كيفك يا أبا عمر؟ شكلك براك لسه.
السلام عليكم دكتور سلوى، كيفك؟
تمام الحمد لله. كيف الأحوال؟
لسه
تمام.
لسه عبرانة والله، اسكتي شوي.
كيف الأمور هناك؟ كويسة معاك؟
والله الحمد لله سلوى بدأت شوية تستقر،
الحمد لله.
بس دارين نجيب أكبر ناس ممكن. اسمعي
والله يا ريت،
عشان
والله
نتغزر.
يا ريت.
أيوه أيوه
يا
والله،
ريت
أيوه والله. لا
لو في
I'm
فرصة.
working on that إن شاء الله.
إن شاء الله. أنت
I'm
في
working.
جامعة ولا مستشفى؟
أنا في جامعة، لكن مشيت لجامعة تاني حس علي زي 2-3 weeks كده. ف I want to explore opportunities like إنه
أيوه.
they are expanding يعني.
برايفت نيو 1.
لا it is a university هنا يعني governmental.
أوكي.
يعني
تمام كويس والله. ربنا يسهل. همتك بس،
إن شاء الله إن شاء
همتك
الله.
معانا.
أيوه
أيوه.
يعني definitely. أنا بقول لهم الناس هنا كلهم
إذا في
بيجيب
تشانس هاي كلمنا.
معاهم ناسهم يعني. فالناس كل ما تتغزر في حتة بيكون أحسن.
طبعا. ربك يسهل الأمور إن شاء الله.
الله.
الحرب دي يعني الإمباكت بتاعها سيء جدا. شفت سوا
أيوه
جابوها كيف؟
أيوه والله أيوه
لا،
والله.
حاجة محزنة خالص خالص.
إن شاء الله يصلح أي شيء، يصلح أي شيء.
طبعا أصله الإنسان موجود بيعمل، لو هو موجود ما في مشكلة إن شاء
أثرت
الله.
فينا، بس نحن زي ما قلت ما في مرح.
ما فاجأتنا، ما خلتنا نقرر. جات فجأة. ربنا يسهل على السودان والله.
إن شاء الله يا رب.
أيوه إن شاء الله. وين باقي الناس اللي معاك؟ ما جو شكلهم لسه.
أيوة لأنه بدينا شوية أبدر إحنا تقريبا
كيف
ساعة قبل
تبدأ؟
الموعد، فرسلت لهم
المفروض نبدأ كم دكتورة تماضر؟ كان المفروض نبدأ كم؟
المفروض أبدأ الساعة 2 حسب الجدول، لكن شوف
لسه another hour.
أيوة
قبل طلبوا كم دقيقة كده للصلاة قالوا.
لكن انت
أيوة.
عارفه الناس خدت امبارح هيبدا نحن الساعه 2، فناس الجراحه.
أيوة لأنه إحنا
هسه انتوا
الصباح
كويس، ناس البصل ديل مشوا سريع كويس يعني.
شكلهم مش سريع.
التوبكس كده هنا ما فيها كلام كتير. انت
فشال وي
حضرتها
ستيك
كلها؟
للتايم يعني.
حضرتها كلها؟
انا كنت قاعد
حضرتها كلها؟
حضرت جزء منها، انا بس كنت شويه شغال وجزء في الطريق سايق العربيه وغايته، لكن موست اوف
كلامنا نحن اللي كان كتير
لا
الزمن.
حول. انت عارفه انا
هاي
امس لما حسيت بنفسي خلاص ما قادره.
ناس الاكس راي دي هاي
ايوه
عندهم
كلام.
حاجات كثيره في راسهم
راديولوجي.
دارين
لا
يديروها.
كلام كتير خالص. بعدين شنو
والله
في وقت واحد.
المشكلة أنا كنت مضغوطة وحضرت المستر عارفني حضرت في شورت تايم. يلا في شورت تايم أنا بعمل المحاضرة اكسباندد وبعد ذاك بجي بضغطها. ما كان عندي زمن أضغط،
انك تضغطيها.
ما كان عندي
هي
وقت
بس
عشان
كده.
أضغط، عرفتها. فتبقى بس جيت بيها
ايوه
كلها كده يعني.
ايوه
التنسيق يعني التنسيق بياخد وقت طويل جدا جدا.
التنسيق صعب.
والله
فمعاه
الظروف صعبة، الناس
كان
كلها.
الله يديك العافيه، ما بتقصر
تتذكر
ابدا.
يوم السبت انا قلت لكم لسه انا ما بديت تو بريبير.
صح.
فكان بالنسبه لي يعني يا دوب لما عملت البريباريشن التاني ما كان تاني في زمن عشان انا اقدر اضغط المحاضره وانقصها ولا ارتبها حسها ذاتها جايطه. لكن قلت خلاص ما في مشكله، بس اقدم زي ما تجي
ناس
كده اقدم.
ضغطت.
ايوه فحقه تاني. حتى اللي اتقدم امس يتقسم تاني في الام دي تيز الثانيه تاني تعاد، لانه كان
ما
في زحمه وكونجستد يعني ما كل
كونجستد.
ايوه
congested
طب ما
حقيقة
دور
congested.
ايوه
المحاضرة بتاعتي أنا
ممكن
بتاعت
ترسلي في
الدي
الجروب
دي
انه
تتقسم
والله
ل3.
السيشن
ايوه
ده حيبدا
قسميه يعني
والله
في
رسلت
MDT
مستر، رسلت في
شويه.
الجروب،
جاهزه يعني.
رسلت من قبل 10
اي
دقائق، لكن ما في تجاوب، بس قاعد ارسل لهم individually
أي
يعني.
أفضل
اي ما هم انت
individual
برسل
رني
عارفه
لهم.
لهم. عارفة رني
كلهم يكونوا
عشان
خاتين.
الواحد ينتبه للصوت، انتبه إنه هنا في مسج.
كلهم
رني لهم.
خاتين انه الساعه 4
انه حيبدا بعد
فبيكونوا
ساعه
عملوا
بس كده.
الارينجمنت.
الساعه 4
فنخليها نبتدي 4 ولا تعملوها 3:30؟
4 دي فيها توقيت.
لا إذا ظهروا نواصل، إذا ما ظهروا بعد ذاك
كويس،
ممكن
نرجع
نديهم شوية.
نرجع
نديهم
شويه.
شوية نديهم شوية نديهم شوية.
اي هو بس شكله الهيستولوجي او الباثولوجيست الليله خلصوا بدري قبل مواعيدهم.
ما
which is
خلصوا
good
خليها
يعني.
بالعكس يعني في وقت كان.
أي والله كويس الحمد لله.
We
يا ريت
stick to the
اسمعي
time ما زي امس.
يعني you stick to the time، لكن يعني كان سبحان الله يعني لو كان عارفين انه حيكون عندكم زيادة. انت كنت حابة لسه انت تتكلمي يعني يا سلوى، كان
ايوه
لسه عندك
ايوه
كلام، كان ممكن تكوني تكملي يعني.
صح، ما في مشكله، المرات الجايه
لكن
في موجوده.
نستفيد من الاكسبيرينس for next
ايوه
time.
ايوه
ما
بالظبط
قصرت يا
كده.
رباب، يديك العافيه.
الله يعافيك.
الله
البلان
يعافيك.
for 2026 it will be instead of every month webinar, every 3 months symposium. يعني حنلم الويبينارات كلها او ناخد توبيك واحد
ايوه
لسيمبوزيوم كل 3 شهور الناس تدسكس ات،
عشان تتحضر كويس حتى.
عشان نتحضر كويس. وكله ممكن الناس تتقسم لجروبات، كل جروب ياخد سيمبوزيوم، يعني not necessarily كل الناس عشان ما يبقى congested. ما شرط كل الناس تقدم في نفس السيمبوزيوم، يعني الناس
بالضبط.
تقسم الطبق ويتقسموا على ال3 سيمبوزيوم. اسم شنو ده؟ حيكونوا حوالي 3، الرابع حيكون أكتوبر.
افتكر كل
3 سيمبوزيوم الناس تختار 3 توبكس وكل مجموعة تاخد توبك يعني. فكده بيبقى شنو كده، بيبقى انه يعني التوبك الناس بتاخد زمن enough time to discuss it thoroughly.
انا افتكر كده
نستفيد منه اكتر.
لو كل جروب عمل suggestion للتوبكس بعد ذاك عشان باقي الجروبس الثانية اللي هي من الراديولوجي والأونكولوجي والسيرجري يتاخد الثيم من المواضيع.
ايوه، ما انا قلت الناس تو سجست التوبكس وبعد ذاك يتفقوا عليها كل الديسيبلينز، وبعد ذاك كلنا مجموعة تختار عايزة تتكلم في اي توبيك. فزي ما قلت لك انه يعني مثلا من الراديولوجي جروب حيتكلموا في التوبيك ده، ما حيتكلموا في التاني، وجروب حيتكلموا في ده، جروب حيتكلموا في ده، بالتالي ما حتكون كونجستد زي دي، يعني مجموعة كبيرة. هو مع انها it is good يعني it is ما حاجة يعني it is advantages ما disadvantages، لكن محتاجة انه بس نعتاد عليها. هل تعرفي انا
بس
بعرف
capacity.
لا انا عارفة ناس يعني قالوا لي انه بيبدوا الخميس الصباح continuously بينتهوا السبت المساء.
حاجه كويس exhausting، لكن مش كده حتكون
دي
مرهقه شديد.
صعبة.
ايوه
التفكير
لكن
ذاته حيكون فيه قليل.
ايوه لكن they are doing like that, they discuss a lot
ايوه
في اكتوبر يعني. هسه في في اسمه شنو ده، في الويبينار مش الويبينار المؤتمر بتاع جدة 3 أيام بتاع البريست انترناشونال 3 أيام.
ايوه و ongoing for 8 hours برضه في ال3 ايام.
ايوه
لا كويس exhausting صراحه، لكن ما في حال، شكله اغلب الناس بقت تعمل كده عشان مشكله الديستنس والترافلينج، فهي
ايوه
بقت more practical.
السلام عليكم دكتورة رباب.
دكتور معاوية، واخيرا اخيرا
ان شاء الله
اخيرا لمينا في دكتور مستر معاوية، الحمد لله على السلامة.
يا مرحبا.
الله يسلمك، كيف الحال؟
الله يكرمك.
ناظر كيفك؟
مرحبا مستر، كيف الاحوال؟
الله كويسين.
تسلم يا رب، الله يعافيك.
والله يا اخي ان شاء الله الناس تاني ترجع البلد وتتلمع في
مش كده؟
بلدها والله يعني الحرب
رب
شتتتنا.
يجمعنا على خير يا رب.
كيف انت حالك
عمي
كويسين؟
ازيك كيفك؟
يا مستر كيف حالك؟ اخبارك؟
ان شاء الله انت كويس.
والله الحمد لله، كيف انت؟
كله
اخبارك؟
تمام. اتلمينا انا واخوك خلاص اتلمينا هنا.
شايف، مبروك والله مبروك.
انا كنت بتكلم معه بكره ماشيين نتغدى سوا ان شاء الله.
يا سلام، والله انتوا اجازاتكم السبت ولا حد؟
ايوه ايوه.
بيجوا
والله
زينا
كويس.
طبعا،
كيفك؟
أيوة خلاص اتصهينوا.
والله نحن هنا شغالين في الخاص طبعا، السبت برضه انا شغال.
لا
والله
حول
طحن.
الله، مشكله.
شغال في
وين انت
الخاص
حاليا مستر معاوية؟
بتعجزوا؟
في القصيم، القصيم عنيزة،
طيب ايوه ايوه.
مستشفى الحياة الوطني.
بتعجزوا
بنشتغل
الجمعه ولا الاحد؟
الإجازة
هي
يوم
الجمعه
الجمعة،
بس.
الجمعة
اه
بس.
اه.
وبعدين دوامين صباح ومساء، تمشي وتجي وتمشي وتجي، حسيت
دي
أنا
دي الكارثه، دي الكارثه، دي الكارثه. انا كنت في السعوديه طفشتني الحكايه دي بتاعت صباح ومسا دي قاتله.
مرهقة، مشكلة مرهقة شديد.
ايوه ايوه.
باقي الأوقات كده ونكول، لكن الحاجة الكويسة إنه في البلاستيك يعني أغلب الحالات كولد، يعني نادر جدا تمشي في وقت غير الدوام يعني.
كويس. that's good. this is good. this is good. قلنا نبتدي شويه ابدر. الناس
كويس.
الباثولوجي خلصوا انه الناس كلها عندها كوميتمنتس. انا الليله عندي امتحان. انا الليله ممتحنين هنا. عندنا بعد ساعتين في مجلس التخصصات شغالين نحن الماستر دي في امتحان الليله. فالليله
ما شاء
يوم
الله.
أو ما شاء الله، أنت نفسك ممتحن مستر عمر، نفسك كأنك داخل في امتحان، يعني كأنك
انا
ممتحن
انا
شباب،
انا
لكن نفسك
ممتحنين الليله
ممتحن.
ولسه
واو.
اسمع نحضر للمؤتمر وما ذاكرنا لسه.
والله
القراية
والله
كانت ساعة.
انا
شغال
قلت
تطبيق.
زوجتي، قلت لها الليله اليوم ده كان مره غايته خلاص نحن تاني ما عندنا مشكله.
تاني بتكون عبرتها مش كده؟
بكون عبرت.
انت غايته، يعني لما تزول ما اعرف حيفضل يمتحن ل 200 كل مره يسألك.
ما عندها
ما
نهاية
هسه
والله،
ولدي
شكله ما
قال لي يا
عندها
بابا،
نهاية.
قال لي يا بابا انت لسه بتمتحن، انت بتمتحن الناس. قلت له والله يا ولدي عشان كده ما داير نقوم تخش الطب ده نحن الا ما بوقفك اي شيء.
حقيقة يعني مثال حقيقي يطلبوا العلم من المهدي للحد.
اي والله اي والله اي والله. يعني
والله.
بيدرسونا كلهم طلبتنا، لكن بس الكويس بيدرسونا هسه في النهايه كلهم طبعا كانوا معانا هاوس اوفيسر
آه
وطلبتنا يعني
أيوه أيوه. لا كويس. طيب
فبكونوا
حيكونوا حافظين
فبكونوا
الجميل أكيد.
بيكونوا هنا غايته ده المعتمدين عليه انه يدونا لقزه شويه.
لا لا أكيد ما عندكم عوجة، بإذن الله موفق.
بالتوفيق يا مستر إن شاء الله قدرة.
امين يا رب. امين يا
ممتحنين
رب.
شنو هو الماستر بتاع شنو يا مستر؟
ماستر بتاع ميديكال اديوكيشن.
الميديكال
آه.
education.
حلو،
السلام
quite interesting.
عليكم يا جماعة، السلام عليكم جميعا.
وعليكم السلام.
عليكم السلام.
ورحمه الله.
مرحبا.
منى ازيك؟
مرحبا، ازيكم؟
ان شاء الله كويسه.
ازيك؟
حالي يا منى.
نورتينا.
زمن
أنا
طويل.
سعيدة بكم بالأكثر. أي والله
والله
طولنا
انا
كثير.
سعيد.
دكتور عمر إن شاء الله أنت كويس، معاوية،
والله
الجميع
الحمد
كويسين.
لله.
سلمي.
الحمد لله.
مرحبا يا منى، مرحبا.
الله يسلمكم.
طيب تماضوا نبتدي 3:30 احسن
خلاص
عشان الناس
تمام،
دي
ممكن
كلها
تمام.
عندها كوميتمنت.
امم
نديهم لحد ونص كده ويستارت.
خلاص تمام.
وين غسان يا منى؟
غسان تخيلي موجود، شايفاه في الكول غسان. افتكر موجود الا يكون بس فاتح الكول وبيعمل في حاجة تانية. كيف يا معاوية؟ ان شاء الله كويس، لسه في السودان؟
والله يا منى لا، حاليا في السعوديه والله.
يعني هربتوا كلكم.
والله هربونا والله. اجبرونا انه نطلع. كويس انه طلعنا حيين.
Exactly. That I just had to shout it out. هربونا وطلعونا.
والله
نادية الضوي معك.
ديوك العدة أنا مسمياهم خربوا الدنيا كلها.
والله خربوا، حتى انتوا اللي قاعدين برا ما تهدوا.
والله نحن ستريس أكثر من الناس.
أكيد.
دكتورة نادية كيفك؟ إن شاء الله كويسة؟
تمام الحمد لله. كيفكم انتوا؟
الله يبارك فيك.
الفتحة بتاعت المطار دي غايته شحتفتنا في الخرطوم.
ايوه
لكن
ايوه انت عارفه كان فتح بشجع ناس كثيره تجي.
لكن المشكلة الواحد عايز at least some sort of security.
الأمراض
ضمان بتاع السكيورتي.
الأوبئة الحايمة دي برضه يعني لحد ما الأمور دي تستغير حتى الناس ترجع.
ايوه اهم السكيورتي، يعني نحن ما قعدنا حضرنا البلاريا حاضريننا والكورونا حاضريننا، ده كله المهم السكيورتي، البيرسونال سكيورتي، ان انت تكون نايم في بيتك ما ينطوا عليك وكلام زي ده.
صح والله صح.
بعدين الحته كلها بقت مسلحه، من هب ودب شايل لهم سلاح.
لا حول ولا قوة إلا بالله العلي العظيم.
فهي دي المخوفانا جدا.
لا والله ما سيف البلد دي خالص من كل النواحي، بس الله يكون في العون.
الحمد لله. الله يكرمك.
أمراض قفلت الفيديو.
السلام عليكم دكتورة نادية.
ايوه كيف؟
انا كويس. انا قايل للناس، انا قايل نفسي قطعت براي فجأة اختفت الناس.
الناس كلها قالت الحق اعمل
لا موجودين، لكن بس هم منتظرين
من حظك
ومستجد.
اوكي.
من حظك يا مستر انه اتقدمت عشان انت
ايوه والله.
تخلص محاضرتينك
امشي
ورا
اقرا.
بعض.
اسمعي
ايوه
الرباب خدت لي شويه بخرات كده امشي اراجعهم.
انت عارف يا مستر اضحكك، بنتي جراديويتد هسه منتظرة لسه ما بدت الامتياز، قالت دي فرصة تعمل فيها هنا ده ماستر بتاع ميديكال اديوكيشن، بتعمل في ماستر بتاع امتحان هسه برضه يوم بعد كم يوم.
بالله دخلت هي هسه. يا اخي دي بالغت. ده
والله
بيعملوا الناس بعد ما يعجزوا الميديكال اديوكيشن ده.
والله قالت تدخل هنا، هي تخرجت من النيلين فعاملة مع ناس النيلين نفسهم، عاملة
عندهم
ماستر،
واحد.
عاملة ماستر. قالت مين هو هاي اللي قاعدة تستفيد؟
دي بنتنا
ايوه بنتكم
هاي.
فعلا عاملة معكم امتحانكم بعد ايام يوم 14.
والله ما شاء الله عليها، هي نشيطه برضه، اشتغلت معي في الاكريديتيشن شغل كثير جدا.
الله
يا عمر الجماعه دول بيعملوا الحياه من بدري. شفت حس الجماعه الصغار ديل كلهم اوريدي عاملين الديجري.
ايوه
صح.
ما زينا نحن
بيني وبينك
they're working in a different style.
اتكلم معاك يا ناديه. it is very important. يعني definitely الواحد حسن شافها. definitely they have to do it early و they have to do it in very important.
لو كلمتني كنت عملت معاكم والله.
بتغير البراكتس بتاعك والتيتشنج everything.
شفت انا حسي في التيتشنج في الجامعات لما كنت بدرس وبعدين بقيت بس بوست جرادويت I used just to give the lectures. شفت لانه لاحظتها لما اجي للايفالويشن ده انا ما بفهم فيه. ف whenever I was teaching I was never involved في الايفالويشن في الاخر. I used to just to give the education lecture. لكن الايفالويشن because I realized immediately that I have no idea of how to do it.
لكن لو عملتها يا نادية هتحسي بالفرق حتى في الايفالويشن assessment of student السكورينج سيستم.
يلا ده انا
how to write a module. حتى لو دايره تخطي كورس تخطي كاريكولم كل الحاجات دي بتكون بالنسبه لك ان سيستم.
انا ما كنت افيليتد للجامعه. انا كنت بيجي وبدي محاضره وبطلع. يعني انا ما كنت اساسا انفولد مع المانجمنت. دي الحكايه اللي كانت حاصله. انا ما شغاله طوالي في حتتين او في ثلاثه
part times.
it was part time but really part time. You know I just gave the lectures. أنا ما كنت involved مع المانجمنت. بكورك بعد مرات when they go above. يعني لما مرة قالوا تدرسي الفصلين ورا بعض قلت له it's unfair. بالنسبة لي أنا كانت unfair. الفصلين لأنه العدد بقى كبير قاموا قسموهم على 2 كل واحد فوق 100 وقال لي تدخلي تدرسي. أنا بديت معهم كان في 91 student فقال لي تدخلي تدرسي ديل وبعدين في يوم ثاني تدرسي ديل. قلت لهم أنا شغالة أساساً. You want to do it بمالتي ميديا زي في السعودية مثلاً. أنا أدرس في القاعتين. المرة الجاية أدرس في القاعة الثانية. قلت it's unfair to give the lecture twice because each lecture is unique. I cannot do the topic لنفس الدفعة هتمتحنون نفس الحاجة مرتين. This is why I stopped and I got them a new lecturer to continue. It was a younger person and she could go through what she wanted. But they didn't believe me when I told them put multimedia so that I can teach both batches in one go. Same lecture.
في السعودية بيعملوا كده بين الأولاد
في السعودية
بيعملوا كده بيدرس في الأولاد. طبعا ما بخلوا الميلز افتكر يدرسوا الفيميلز فهو بكون بالسايد بتاع الميلز وبعدين دي
فقلت لهم it's available. يعني ممكن حاجة تعملوها. that's why I stopped. في الآخر أنا بقيت بس البوست جرادويت ومينلي in the lab. يعني وقفت لأنه لقيت المجال ده بقى واسع وما فاهمة فيه.
It's never late.
طيب المفروض نبدأ بعد كده
غسان ظهر. أيوة مستر غسان ظهر.
كيف أخبارك؟
السلام عليكم يا مستر
وعليكم
عمر.
السلام.
كيف
إن شاء الله
أخبارك؟
طيب يا الحمد لله.
الحمد
زمن يا أخي
لله.
ما شفناك. كيف أخبارك يا
طويل. طمنا عليك أنت كيفك؟
والله الحمد لله هو في حال الدنيا الحمد لله.
ما لأنه ما كان بيقدر يحضر معانا السبت.
يا غسان كيف الحال؟
مستر معاوية كيفك؟ كيف
كويس.
أمورك؟
أخبارك؟
والله يا أخي والله لما جميل خالص. كيف الأمور؟
والله يا أخي
تدفعوا بس تدفعوا ما ساي.
عشان يدفعوا لك المغتربين احنا ما
لندن والله. تمادر.
ايوه طيب تمام نبدا.
بسم الله.
طيب نبدا. بسم الله. السلام عليكم ورحمه الله. Welcome to the second part of day 2 of the fourth symposium, and the session will be focusing on the surgical aspects or discussing the surgical aspect in the treatment of early breast cancer. Before we start that, I would like, on behalf of my whole team in the surgical team, to thank the organizer of this symposium for the great work and incredible work they're doing, keeping the wheel running despite of the challenges, and being able to conduct this fourth symposium despite of all the distances and the other challenges. So thank you so much and may God rewards you for this and accept all your deeds, inshallah. So the first speaker in this surgical session will be Mr. Omar Al-Faruq. I would like to introduce him. He is Associate Professor in Surgery in the Faculty of Medicine at Khartoum University, and at the moment he is practicing at Ajman University Faculty of Medicine, and he's also Head of Surgical Department at Soba University Hospital. So in this session, we'll be discussing the surgical axillary management in early breast cancer, with more emphasis on the de-escalation strategies in surgical management in early breast cancer, and more focus on the SOUND trial and the more advanced and innovations in management. So thank you, Mr. Omar Faruq.
شكرا جزيلا دكتور تماضر، وشكرا للجنة المنظمة for organizing such a great symposium, especially نحن في الظروف الضغط المرمى الأيام دي. thank you تماضر for the great effort of choosing the themes for the surgical presentation. I think it was a great choice. يعني هي تماضر ادتنا كده، يعني she imposed on us what to present، ومن عينتها للثيم كله مع بعض شفتوا حاجة ماشية مع بعض وحاجة جميلة. Well done و thank you very much for everybody. طيب I will share my screen now. اوكي طيب انا I have two presentations كنت المفروض اقدمهم في كل واحده مختلفه في different time في السيشن ده، لكن I choose to do them together لانه for pressing issues. و I'll try اكون خفيف عليكم ان شاء الله. I will just whip through the sound trial. انه both presentation are related, so hopefully the first one will be as a completion for the second one. We'll whip through the sound trial quickly, and then we'll talk about the trials for the auxiliary management في early breast cancer. شايفين الشاشة؟ واضحة؟
أيوة واضحة.
Okay. طيب historically the lymph node dissection كان بنعمل complete axillary lymph node dissection. ده الستاندرد كان و it is associated with very high morbidity. وبعد فترة الناس they shift to the sentinel node biopsy. This is because of the reduced morbidity, and it becomes the standard for the early breast cancer care. Then في three major trials, they change the attitude of the surgeon towards, actually the attitude of everybody towards managing the axilla، اللي هم كان ال ACOCSG اللي هي الزو 11 والIBCSG والأمروس trials. They'll show no survival benefit from the axillary lymph node dissection. we'll go just through them quickly لأنه كانوا major change في our attitude towards the axilla. الquestion اللي هي نحن actually we posed this question before this trial come out. يعني نحن من 2009 2008 we are talking, is sentinel lymph node, even the sentinel node is still necessary إذا أنت you have a small cancer والauxiliary lymph node clinically negative والultrasound negative, do you still need to do a sentinel lymph node biopsy? And the other question, even if you do the sentinel lymph node biopsy and you will find that you have 1 or 2 lymph nodes, do you still go for auxiliary lymph node clearance, or you just do that and you stop at that time? Do we need to give patient radiotherapy after they have the axillary node dissection? And more urgent question we really raised, and actually all the surgical community and the oncology specialists, oncology people raising is, after the new adjuvant, do I need to go aggressive with the axilla? So all this question make people do more trial to understand if we don't do those things, what's going to happen. فاللاندمارك trials as I say كانت الايرلي ترايلز اللي هي عملت تشينج في الاتيتيود اوف سيرجن اند اونكولوجيست. هي واحده منهم كانت الزو 11 والبوبيوليشن كان women with T1 T2 invasive breast cancer وما كان clinically they don't have lymph nodes والترا ساوند ما عندهم lymph node و they undergo breast conservative radiotherapy. They divide the population to centillion lymph node biopsy alone plus والother arm كان centillion lymph node biopsy. إذا كان 1 or 2 بيعملوا لهم axillary lymph node dissection والother group إذا كان 1 and 2 ما بيعمل لهم centillion lymph node biopsy. فالfinding إنه كان no difference in the overall survival والdisease free survival والregional recurrence. فديس showed ودي عملت حسها change كبير جدا. This study make people now, if they have 1 or 2 lymph nodes, they don't have to go for axillary lymph node dissection. Before that, if the sentinel positive, you go for axillary lymph node dissection. So it is a major trial which had changed the attitude. The other one is the IBCSG. دي عملت إنه population النود نيجاتيف برضه لكن كان فيها مايكرو ميتاسيسز. This goes without saying. إنه the same will happen if you do centillion lymph node biopsy and it came as positive. You just stop at that level. So do we do centillion lymph node biopsy alone or do you need to proceed for axillary lymph clearance? And obviously the findings, there is no difference in the disease-free or overall survival. بعد كده another trial actually, which I really think that this trial result will influence still our future practice with the axilla. كان في population invasive breast cancer with positive sentinel lymph node, الانترفنشن axillary lymph node dissection or giving axillary radiotherapy. يعني في ناس يعمل لهم axillary lymph node dissection وناس just radiotherapy without axillary lymph node dissection. والconclusion إنه axillary radiotherapy is as effective and less morbidity as alternative to axillary lymph node dissection. ودي زمان احنا كنا بنفتكر انه والله الراديوثيرابي will cause more morbidity كده. This study showed that it's less morbidity is as effective as complete axillary lymph node dissection. So these 3 trials were the first trials. بعدين جات the sound trial اللي هي نحن المفروض نتكلم عليها الليله. فهي دي السنتينيل lymph node biopsy في sound trial is standard for axillary staging in early breast cancer. We provide axillary lymph node and they think still axillary lymph node is important. It provides prognostic information but not proven therapeutic benefit. لحد هسه الناس بدوا to question do that lymph node status decide about the therapeutic benefit, yes or no. We'll talk about this later. So the objective of the sound trial was test if omission of sentinel lymph node biopsy is non-inferior to sentinel lymph node biopsy in terms of 5-year distant disease-free survival. ناس ناخد لهم sentinel وناس especially في T1. The secondary endpoints was disease-free survival, overall survival, axillary recurrent, والadjunct therapy recommendations. Trial design كانت phase 3 multicentric non-inferior randomized control trial اتعملت من 2012 ل 2017 لكن الريزلت بتاعتهم has been published في 2023 فأخذوا شوية تايم. دي كانت واحدة من الدروباكس بتاعتهم. Population woman with invasive breast cancer less than 2 centimeters, so we're talking about T1, clinically node negative, clinically and radiologically node negative, who they are randomized to sentinel lymph node biopsy versus no axillary surgery. وكانت في different hospitals. I will just whip through it quickly. Eligibility is, as I say, tumor less than 2 centimeters, negative axillary lymph node. البلان كانت breast conservative surgery plus radiotherapy. So في التو جروبس الناس اللي أخذوا لهم sentinel والناس اللي أخذوا sentinel ما أخذوا في التو جروب they have radiotherapy. ف برضه I will go through this quickly. الrandomization in everything was identical. يعني في الايدج جروب، في الستيجنج، في الجريدنج، كله كان identical في التو جروبس. البيز لاين كاركترستيك كان الميديان ايج بتاعهم 60 والميديان تيومر سايز 1.1. الاي ار بوزيتيف هير 2 نيجاتيف. This is important لانه في كل المرضى كانوا اي ار بوزيتيف هير 2 نيجاتيف most of the patients. والسنتينيل نيف نود ارم من عملوا السنتينيل اللي هي كانت كلينيكال وراديولوجيكال نيجاتيف في 13.7 has nodal metastasis. لكن الانترستنج انه في الادجوانت في التو جروبس الهرمونال ثيرابي في التو جروبس almost 90 to 95% of patients had hormonal therapy. الكيموثيرابي كانت 20 و 17%. وراديوثيرابي almost all those patients had radiotherapy. التروسودوماب في بوث كان 6.6 لانهم كانوا كلهم ER positive hair negative في البوث جروبس. فالحكايه اللي انه ال5 year survival الديستنت ديزيز survival في التو جروبس is 97% لانه احنا talking about early breast cancer. وال5 year برضه انك طبعا الكومباريزون انك تعمل لينف نود بايوبسي سنتينيل ولا ما تعمل كله وتدي راديو ثيرابي بس. ف ال5 year برضه كانت the same is good. وال5 year overall survival كان almost 98% in both groups. So الاكزيلري ريكارنس كان 0.4 في both groups والناس اللي ما شالوا لهم حتى السنتينيل. الديستال ميتاستاسيس 1.8 في both groups similar. اللوكال regional relapse is almost the same و no significant difference في everything تقريبا between the two groups. طيب let's just do some discussion here. Omission of sentinel lymph node biopsy is safe for low risk patient. يعني اغلب الناس اللي كانوا في الترايل ديل هم low risk patient T1 و lymph node negative وال equivalent outcome in survival and recurrence common with compared with انه نعمل sentinel node و avoid الموربيديتي والless lymphedema وال improve الارم function. لانه الناس اللي كانوا في الجروب نفسهم مرات في الجروب الثاني اللي بيعملوا له سنتينيل اذا كانت بوزيتيف بعض منهم كانوا عملوا لهم اكزيلري لينف نود دايسكشن وفي الاخير كانت الريزلت ذا سيم. طيب يبقى التريتمنت ديسيجن فور ذيس جروب از جايدد باي ذا تيومر بيولوجي الاي ار اتش الهير2 والجينوميك اسي اللي هي الريكرنس سكور ما كان جايدد باي الليمف نود ستاتس. بالتالي نحن بنحتاج للليمف نود ستاتس في الايرلي بريست كانسر is when you have a young premenopausal woman. ودي عملوا استدي ثانيه اللي اسمها الاركس باوندر ترايل في نفس الناس اللي هم الاستروجين بوزيتيف هير 2 نيجاتيف ولقوا انه they compare انه الريكرنس سكور بتاعهم مع الليمف نود في اليونجر ايج جروب فلقوا انه adding the lymph node will influence the treatment decision لانه لقوا في اليونجر جروب نفس الكاركترستيك دي ممكن يدوم كيموثيرابي in addition to the hormonal therapy. فهنا الليمف node is useful although just take this in the future I think there will be more prognostic factor like now the recurrence score and the other like the what you call the
DX.
Yeah, it is more now in the future. I think most of the decision will not be dependent on the lymph node. Although for now the evidence show that in young patient you still need to do the lymph node to decide about the chemotherapy. ER HER2 negative patient also to decide about the endocrine therapy. And in the HER2 positive or TB negative cancer, also the systemic therapy and radiation planning also depend on the lymph node. High nodal burden, we're talking about more than 3 or more with the lymph node will be of prognostic impact. So on those cases, you have to consider doing the lymph node staging as you used to. When auxiliary surgery remain relevant, as I say, younger patient, chemo decision tied to nodal status, high-grade aggressive tumor, nodal information may give guide the escalation of treatment. HER2 positive, triple negative cancer, node staging informed systemic therapy. وبعدين الراديشن بلاننج إذا كانت برضه high nodal impaction. الليميتيشن بتاعت الاستدي فيها limitation انه they report late وكده. we're not going to go through that. الclinical implication, it supported deceleration of auxiliary management, may influence guidelines on mid-sentinel lymph node when nodal information does not alter the therapy. And this second line, I think in the future will really influence our management for the axilla. Could reduce the cause of morbidity, allowing with choosing wisely recommendation. Thank you very much. This is my first part of the presentation. If you had any question before we proceed to the next stage, or we leave it to the end.
Yeah, we can leave it
to the end. Okay. So the other part of the talk is management of the axilla. Again, I'm just going because it is really still all surgeons and oncologists, they are really arguing about how to manage axilla. So that's why the shift from extensive axillary surgery to deceleration, as we said before, early landmark trials اللي اتكلمنا عنها الاسكوس والزو الاقصد الزو والاي بي سي اس جي والامروس, they are very crucial trials. بعد كده وكان الجول is reduce morbidity while maintain the oncological safety. طيب في التوك ده في حاجات بس terminology عشان بعدين all of us, I know most of you you know all this, but we have just to clear it. Sentinel lymph node, we know about it. Axillary lymph node dissection, which means axillary node dissection level 2 or 3. Regional nodal irradiation, that we mean by that to the axilla, supraclavicular, infraclavicular, and internal mammary lymph node group. And YPN0, no residual nodal state after the neoadjuvant treatment. Just to know this glossary because it's important in the rest of the discussion. TAD اللي هي targeted axillary dissection, we mean by that removal of the clip node plus the sentinel lymph node biopsy. طيب شنو now الستاديز اللي اتكلمت عنها اللاندمارك ستاديز, وكان الكويشن and I posed before انه do we need to know more? People are now taking those questions or the question they have in mind, and in the last 1 year there is several trials going on, done or going on. So the ENSEMA, which is published in 2024, they compare no sentinel lymph node to sentinel lymph node in CN0. لكن هنا بدل زي الساوند ترايل كانت T1. هنا دي في الانسيما ترايل دخلوا T1 و T2, وبعدين they included more younger patient pre-menopausal عشان دي كانت mainly في شويه البوبيوليشن بتاعها كان older age group. هنا دخلوا more younger age group وكانت في T1 و T2, والاوتكم انه again the disease-free survival at 6 years is almost the same. بعدين دي الساوند ترايل اللي احنا اتكلمنا عنها وانه الاوتكم كان no different, لكن زي ما قلنا الانسيما ادت more insight about this N0 population even if they go to T2 or they been younger patients. بعد كده في اذا كانوا دي نحن الانسيما دي بنتكلم على clinically negative. اذا كان النوت positive after the surgery فاللي هي 1 to 2 nodes بعد السيرجري, فجات واحده الترايل دي السونوم في برضه في 2004 السينوماك عملوا ترايل between no axillary lymph node dissection versus axillary lymph node dissection, والاخير كانوا اخذوا راديوثيرابي. نحن نتكلم عن 1 to 2 sentinel lymph node biopsy, انه ما يتعامل لهم بعد كده واحد ناس عندهم 1 to 2 nodes ما يتعمل لهم axillary dissection after that, وفي ناس عمل لهم axillary dissection والاثنين ادوهم راديوثيرابي. يعني in 1 and 2 ما تعمل axillary lymph node. الاوتكم it is no inferior recurrence, free survivor, less lymphedema, so it is the same. البوزناك دي حاسه لسه شغاله. no further auxiliary treatment, no radiotherapy. يعني حتى انت بعد ما انك في 1 و 2 ديل بعد ما تشيله، ما انك بس no auxiliary dissection but in addition ما تدي radiotherapy خالص حتى في ال 1 to 2 دي. فده comparing انه الناس اللي تعمل لهم 1 to 2 lymph node ديل ما تديهم radiotherapy لناس تعمل لهم auxiliary dissection وناس تعمل لهم radiotherapy بس. فدي still ongoing في الترايل. طيب اذا كان السنتينيال ليف نود بوزيتيف افتر سيرجري دي اتكلمنا عنهم السوناك والكده. الكلينيكال نود بوزيتيف كانوا سي ان من الاول، انت كانوا الليف نود بوزيتيف. ففي التاكسس دي برضه لسه شغاله، انه دي ongoing trial انه تعمل targeted auxiliary surgery plus radiotherapy. يعني انك تشيل بس الليمف نود الانفولف السنتينيال بلس الانفولف ليمف نود، وناس يعمل لهم اكزيلري كليرنس، وفي الاثنين تديم راديو ثيرابي. Is it going to be different؟ لقوا انه لسه طبعا دي is ongoing، وهيشوفوا انه السرفايفل اوت كم فيهم. After a new adjuvant اتكلمنا. طيب انت عملت النيو ادجوفنت وجيت لقيت المريض ما عنده ليمف نود خالص، واللي احنا من زمان اتكلمنا فيها انه ليه انا تاني اعمل له سنتينيال ولا اعمل له كليرنس؟ انت هي ما نيجاتيف وديته كيموثيرابي وبعد شويه هتديه راديو ثيرابي. Do we need to do that؟ فجات في ترايلز زي دي حسها ببلش ال NSAPP دي ببلش في 2025 انه omitting a radiotherapy versus adding radiotherapy in a clinically positive lymph node اللي كانوا نيجاتيف خالص ديل. هل نديهم radiotherapy ولا ما نديهم radiotherapy؟ ولقوا انه no different in invasive recurrent free survival between the two arms. Regular recurrence is less than 2 in both arms, similar. والconclusion انه regional node irradiation can be omitted in YPN0 after neoadjuvant treatment. So after a neoadjuvant residual node positive، انت اديت عملت النيوادجوفنت وبقت لسه في نود بوزيتيف. في ترايلز جوين هسه انه نعمل اكزيلري راديوثيرابي ولا نعمل لهم اكزيلري كليرنس. يعني انت زول اديته نيوادجوفنت وجيت بعد النيوادجوفنت لقيت لسه في جزء من الليمف نود بوزيتيف، فهل انت تديهم بس راديوثيرابي ولا يو جو فور اكزيلري ليمف نود كليرنس؟ ودي ongoing trial لسه. و انه الهايبوثيسيس انه radiotherapy will be non-inferior to avoiding morbidity from auxiliary lymph node clearance. تمام. التارجت auxiliary dissection الترايل الشغاله انك تارجت دي قلنا انه يريموف السنتينيال lymph node بلس الكليب نودز. فالفي الاكسانا اللي هي دي ongoing انه سنتينيال lymph node plus targeted versus auxiliary lymph node dissection after neoadjuvant. الاوتكم انه لسه طبعا he's an ongoing trial والاim is to define long-term safety avoiding auxiliary lymph node dissection in a neoadjuvant treatment patient. So emerging predicaments is that surgery, selective omission were safe, radiotherapy tailored not flanked, systemic therapy and imaging guide auxiliary management. The overall trend is less surgery, more precision. Well, a practical takeaway is the omit the sentinel node is safe in small ultrasound negative tumor. The sound والإنسيما trials. 1 to 2 positive sentinel lymph node you can omit auxiliary lymph node dissection. They according to the SYMPOSIUM trial. والpost new adjuvant اللي هي ال YPN0 you can omit الراديشن دي في البي 51 trial. والريزيديوال نود بوست نيو ادجوفنت auxiliary lymph node or radiotherapy دي نحن نعمل ياتوفيهم awaiting الريزلت. واذا كانت الليمف نود positive after النيو ادجوفنت التاكسس may allow auxiliary lymph node replacement with radiotherapy only. والثالث قلنا التارجت auxiliary dissection is visible validation is ongoing for trials بتاعت الثالث. a theme deceleration with safety. طيب, did the trials, as we saw, it is important to know all that. I think in the next 2 or 3 years, so much will going to change, and deceleration will be the theme for the axilla. So the last part of the talk, I'll just whip through the option that you have for the axillary management. And no management of the axilla have evolved for the last decade. Axillary node metastasis is significant prognostic factor in breast cancer, influencing surgical and adjuvant treatment. While the surgical approach to the axilla has become increasingly conservative, the optimum management of the axilla continue to be controversial topic. Traditionally, طبعا كل البيشنت كانوا بيعمل axillary lymph node dissection, لكن now axillary lymph node dissection, we all know it is associated with high morbidity, lymphedema, impaired shoulder movement, and arm sensation, resulting in considerable impact. And the most important thing, it is not therapeutically advantageous over the other options. This is just a slide I have for a long time. إنه الفولس نيجاتيف ريزلت إذا أنت عملت سنتينيل ليمف نود is 10%، إذا عملت تارجت ليمف نود is 4.6، إذا عملت السنتينيل والتارجت ليمف نود الفولس نيجاتيف will go to 1.4. طيب ال NCCN الكي challenges and recommendation recently إنه deceleration of axillary surgery, the guideline continue to move away from the routine axillary lymph node dissection. والسنتينيل lymph node is the standard، لكن for clinically nodal negative patients, sentinel node is the recommended approach for assessing the axilla. والlimited axillary lymph node dissection, extensive positive sentinel node finding اللي هو more than 2 or 3 depend on surgical approach or when the axillary status is impact the treatment. The impact of neoadjuvant therapy إنه the effectiveness of neoadjuvant chemotherapy has increased the rate of pathological complete response وكده allowing for further deceleration such as avoiding axillary lymph node dissection or radiotherapy. A regional node irradiation may be used in conjunction with sentinel lymph node biopsy in certain patient group as supplement to avoid more expensive surgery. دي ال NCCS ال NCCN guidelines recent. طيب المابينج بتاع العناية أنا تماضر she asked me to go through this and I try to go through them very quickly if you allow me. تماضر, do I have time or?
Yeah, you do still have time, Mr. Omar.
Okay. So sentinel lymph node mapping طبعا التكنيكس انا will go through the techniques. التكنيكس هم في الراديو تريسر بلس بلو داي، في عندنا الراديو تريسر، عندنا البلو داي، في عنده اندوسيانين جرين طبعا غسان know that very well بيستعملوه ناس غسان. عندنا اللي هو الاي سي جي، وعندنا الماجنتيك تريسر، وعندنا الالترا ساوند guided biopsies. وفي الأوسانة دي إذا عندنا تايم نتكلم عليها later. طيب التكنيك في قلنا الديول تريسرز اللي هي التكنيشيوم دايد الاندوسيانين داي اور مثلين بلو. عندنا الاي سي جي هو افويد سكين ستيننج ريال تايم فيجواليزيشن. والاس بي اي او ده اللي هو التريسر الماجنتيك تريسر useful when especially when you don't have a nuclear medicine is limited in your hospital, so it will be a good option to use. والcontrast enhanced ultrasound دي visible ودي is a good modality. It's coming to the surface, actually it's coming for a long time, like it is a good modality, but it is an operator dependent. I'm going to talk about it in a few minutes. طيب نتكلم عن sentinel lymph node. الراديو تريسر التكنيشيوم اللي injection of peri subareolar peritumoral intradermal ده الانجكشن تايب. It is short. في عندنا two protocol. في واحد short protocol اللي هي انت you can do the injection 2 to 6 hours pre-operative, or a long protocol ده depending على التريسر اللي انت الراديو تريسر اللي you are using. ده الثانية ممكن you have to do it that day before the procedure. والdetection rate بتاع الراديو تريسر is usually more than 95%, especially if you use معاها الميثيلين بلو بيبقى more than 98%. الادفانتج بتاعت الراديو تريسر is a high accuracy والdisadvantage انه require nuclear medicine والcost is moderate to high يعني انه لازم يكون عندك راديو ايزوتوب فاسيليتي واللوجيستيك بتاعتها والتريسرز اللي انت بتستعملها في الاوبريشن فالكوست is to start with is significant cost لكن once you establish your services is going to be of moderate cost. دي التريسرز بتاعت الراديو ايزوتوبس نحن شفناها طبعا في السودان ما عندنا كثيره انا me and Tomadur were lucky to observe it in Bahia في Egypt. السنتينيل لينف نود الثاني البلو داي الانجكشن برضه بري انتراديرمال بريتيومرال تايمينج انتراوبراتيف 10 to 30 minutes before the incision. Detection rate is 80 to 85 alone وطبعا كان عملناه مع حاجه ثانيه will increase مع الراديو تريس. Advantage is immediate, no special equipment. A disadvantage انه sometimes it cause allergy و tattooing والcost is low و very useful in our situation especially in Sudan and we are using it extensively in Sudan. دي طبعا المسلين بلو. الثاني الاندو ثيانين جرين الانجكشن is subdermal or subareolar timing intraoperative just before the incision يعني it doesn't need long time. The detection rate is very good more than 95 similar to the radio tracer و real time visualization و avoiding tattooing. ده طبعا special camera وهو عنده disadvantage انه في limited penetration فالcost will be initially high with the cameras وكده لكن once you establish your facilities it is a good alternative if you don't have the radio isotopes facility. عصام ممكن يكلمنا عنه بعدين في الآخر شوية. This is the radio iso cyanine. This is how you detect it with the camera. The other thing we can use is the supraparamagnetic ion oxide واللي هي الماجني تريس بالمagnetic. فالinjection usually subareolar time flexible days to week before the surgery. The detection rate is 95 to 97. It's very good, non-inferior to the radio tracer. وزي ما قلت it is advisable, not advisable, but it is best. It is a good when you don't have the radio isotope facilities. Both of them, I think, the green and the mag tracers are good when you don't have the radio isotope facility. A disadvantage in skin staining, MRI artifact device بيعمل MRI artifact especially if هتعمل more if you are planning to do more MRIs for follow-up you don't use this technique because it will interfere with the MRI. The cost is moderate device والtracer وكده moderate to start with بعد كده بيبقى is alright. The device of detecting the tracers طيب الآخر يعني الحاجة الثانية الحقيقة contrast enhanced ultrasound this is getting popularity لكن it is operator dependent. We use a micropupils contrast agent sulfur hexafluoride micropupils injected intradermally or peritumorally. Micropupil travel through the lymphatic to sentinel node which can then be visualized in dynamically under ultrasound. تقدر تشوفها بالultrasound before the surgery طوالي immediately or during the surgery and then you can localize the lymph node which you can see with the ultrasound. والinjection زي ما قلنا time in real time pre-operative immediately before surgery detection rate is 80 to 90 والadvantage no radiation advantage operator dependent. ودي كده دي بتشوفوها بالالتراساوند especially بالداي بتشاف بالالتراساوند you can detect the node very clearly and then you can put a clip or you can isolate the node during the operation or you can put a guide wire on the detected node for the surgeon to take during the operation. فدي تقريبا التايمينج. I can leave this slide for you بتاع كل الموداليتيز. طيب for targeted lymph node localization في كذا طريقه انا just برضه whip through them quickly. الفيجوال تكنيك وده الموست cheaper وانا شايفه الموست suitable to our situation. although حتى في ال developed countries زي جيرماني بيستعملوه extensively انه they go الليمف نود السسبيشس يحطوا فيها charcoal tattooing. يعني بيعملوا تاتوينج ودي بعد كده whatever بعد المريض ياخذ علاج وياخذ new adjuvant when they come to surgery they will find this tattooed lymph nodes في الاكزيلا. او نعمل ايمج جايدد تكنيك ناخد في الليمف نود كليبس اور كويلز. طبعا نحن التارجتد لوكاليزيشن دي بنعملها للناس اللي حياخدوا كيموثيرابي نيو ادجوفنت على اساس انه when they come for target lymph node dissection will be easy. فالايمج جايدنج كليبس كويل with wire or ultrasound localization. وفي البروب جايدد تكنيكس. البروب جايدد تكنيكس اللي هي ناخد فيها magnetic seeds ولا راديو اكتيف سيدز ولا راديو فريكونسي سيدز اللي هي can be detected. ده الكربون تاتوينج اللي قلت لكم انه is very useful. You can just tattoo the lymph node with charcoal and it can last forever. فبنتجي بعد it's very cheap. ودي الالتراساوند جايدد ناخد في ال suspected node ناخد كليبس ولا سيد في targeted lymph nodes. And then you can dissect it localized during the operation. الكليبس بالالتراساوند والسيدز نفس الحكايه. البروب جايدد تكنيكس البروبس جايدد اللي هي البروبس اللي عندنا اللي ممكن ناخدها في النودز دي اللي هي في الراديو اكتيف سيد دي not available in every country due to radiation protection regulation و very expensive. فدي it's not practically is not used. المagnetic seed طبعا available it's very expensive. الرادار seeds more expensive than the magnetic seeds. والراديو frequency identification tags دول كلهم حاجات ممكن تتخطى و you can identify them by machines. الحاجات دي detect them بالماشين زي الراديو سيد والراديو frequencies كل الحاجات دي. So in conclusion, modern breast cancer care less is more. Shift from radical intervention to minimal invasive evidence-based approach. Avoid over-treatment while maintaining the oncological safety. Deceleration, shared decision-making with patient, clear communication of treatment intent and expected outcome, precision medicine and tailored therapy. And just remove this. Okay. Just go back. معلش في فقلنا البريسيشن ميديسين and tailored therapies وتريتمنت بلان adapted tumor biology. دي مهمة. التريتمنت بلان is adapted to tumor biology, patient profile and the life goal of the patient. And the decision in the future will be about the biology, about the genomic, about a lot of things. And I think nodal status will not be part of them. Thank you very much.
Thank you, Mr. Omar. Great session, quite thorough, and covering almost all the modalities of axillary management. So we can take the questions at the moment. We do have one question online that Dr. Ghada asking, what do you do if you got 2 out of 2 positive lymph nodes in the sentinel lymph nodes?
Okay. Nowadays, I mean, if you got 2, people usually try to get more than 2 in the sentinel lymph node. But if you got 2 out of 2 with this, I'll tell you what, you have to, number 1 is to see what your preoperative finding is. The ultrasound is negative and there is no lymph node, or are they positive? And then when we take the lymph nodes and you get 2 out of 2, you take other things into account. But the guidelines, if it is still 2, you will stop at that level. I mean, you don't need to do further thing. But I think it is not a simple decision. It's not 1 + 1 = 2. It is, you have to take a lot of information to decide. But the guideline, if you are talking just about the lymph node, people are saying that less than 3, which is 1 or 2, is positive. You can omit the axillary lymph node dissection.
Okay,
And
good.
other people can correct me if I'm wrong.
Yeah, we can listen to the other panel as well. What do they do in their
Well,
practice?
Yeah, please.
I think you are right, Mr. Omar. Sorry to just to go to it. You are right, because other parameter criteria should be considered, and we should discuss this case by case. So for this patient, we have to consider the cancer biology, the age of the patient. All that will guide us to where to go. Either to go, because radiotherapy, as you said in your presentation, is not inferior than the axillary node clearance with less morbidity. So we'll consider all that criteria, and then we discuss it as multidisciplinary team and to decide which way to go. I completely agree.
All right, great. And what about the other practice in different countries? Mr. Muawiyah, Ms. Aida, from your experience and from your practice, how do you approach such situation?
Yes, Mr. Omar is right, to see other factors and to consider other factors to decide the situation.
All right, great. Any further questions, any points to discuss?
Well, I got just a comment. Thank you so much, Mr. Omar. Really great presentation, and you covered most of the ongoing trial to de-escalate axillary surgery. I just recently presented this topic in conference in Romania, and you covered actually all this trial brilliantly. Just to add that the role of sentinel lymph node biopsy in DCIS, because DCIS is early stage breast cancer. Just for the trainee, just to let them know, most of the trial, either UK, European, or ASCO, all of the trial, all of the guidelines advise not to do axillary node surgery for sentinel lymph node, for DCIS, unless if we are doing breast conservation surgery, unless there is high risk of invasion, expectation of this DCIS to get to invasive stage, which is indication is either mass forming DCIS or extensive DCIS. And most of guidelines advise to sentinel lymph node biopsy or axillary surgery if we are performing a mastectomy for DCIS. But with recent invention, as you said, with SPIO, which is a MAC trace, supraparamagnetic ion oxide. So with this invention of new trace that can stay for weeks, even for mastectomy, because there is a big Sweden trial, it's called Sentinel. So in Sentinel, what they have done, they have done a mastectomy for sentinel lymph node biopsy, and only they injected the MAC trace. They injected it pre-operatively, and they left the patient alone without doing any sentinel lymph node biopsy till we got the results of histology. And with this trial, they saved nearly 80% of patients to have a sentinel lymph node biopsy, and we know there is definitely morbidity with any operation. So with Sentinel trial, even with mastectomy, we don't need to do axillary node surgery for mastectomy for DCIS. So I just wanted to flag up this point, because you covered everything. Otherwise, you've covered it brilliantly. Thank you, Mr. Omar.
Thank you, Muna. Thank you. That really great points. I will be exploring this in more details in my session during the DCIS management. So thank you for giving the highlights for that. I would like to comment also from my side about the axillary management in node positive pre-neoadjuvant and post-neoadjuvant patients. At the moment, Muna, you can comment on that with your experience as well in the center, because here in the center, in the Mermis Center, in the southwest area of the UK, we're not really following or adherent totally to the guidelines in the management of axillary lymph node positive disease in the axilla pre or post neoadjuvant. What we're doing at the moment is that if we still find positive disease in the axilla after neoadjuvant through doing target axillary lymph node dissection, we tend to categorize those patients into high risk or low risk patients. If we think the disease biology and the patient characteristic are more into low risk category, we send the patient just for radiotherapy we don't go back for dissection
Clearance.
or clearance, exactly. Otherwise, if we think it's a high risk with a high burden,
كان دكتورة مرحبا.
then we go for clearance. So yeah, that's quite interesting because I think different centers, they do have different policies and different local practice.
Yeah. Yeah, you're right. Yeah.
Yeah.
Yeah, but there is some.
الحاجة الأخيرة كنت داير to mention it يعني إن شاء الله it will appear برضو very soon اللي هي الأسنة اللي هي one step nucleic acid amplification technique اللي هي إنه nowadays في trials مش trials في يعني people they are taking the lymph node during the surgery instead of doing the frozen section or just wait for the result of the sentinel node, they take the nodes and they detect the DNA assay اللي هي to detect الcancer cell في الnodes. And the assay can give you the result immediately to tell you is this lymph node containing malignant cell or not. So this is most probably the near future will also be a major player في auxiliary lymph node scenarios. انه getting a lymph node وطوالي detect يعملوا assay DNA assay للmalignant cell and they can tell if this lymph node containing malignancy or not, which is OSNA.
And
One step.
Mr. Omar, just a comment about that because this is will contradict the concept of de-escalation. So if we found the cancer cells at the same time, they have to do clearance, isn't it? They have to do clearance.
No.
So this will contradict the concept of
I know
de-escalation.
I agree to some extent with you, but it is like if people still, I mean, I'm not talking about the future of clearing the lymph node, but if you take this lymph node instead of doing the sentinel lymph node and wait for the result, that can help in the future to just immediately tell about the lymph node. I agree with you. It will agree and not agree, because we agreed now, even if lymph node is positive, you don't need to do major things about this patient, because radiotherapy can be as good as the other thing is the
or no
leaving
treatment
even
or no treatment
or
as
no
you
treatment.
said. Yeah.
Agree. Just another aspect the junior should look at.
Yeah, exactly, Mr. Omar. But I think the OSNA, the basic concept of it is that having immediate answer, isn't it, intraoperatively, whether that lymph node is involved or not. Then we go for the next step of axillary clearance.
Yeah.
So that has been the practice of OSNA. At the moment, it's not that part of the practice, isn't it? It's not anymore part of the practice because we're not doing axillary clearance based on that decision immediately.
Agree. Ghassan, do you have anything to say about the idocyanine green?
طبعا مستر عمر انت يعني very optimistic about our practice. يعني في يوكي هنا طبعا احنا ناس بتاعين cost effectiveness. هي طبعا very nice way to see the lymph node الاندوسيانين green زي ما انت described it, like injecting وبعدين الكاميرا فيها near infrared kind of light وبيخليك تشوف الإيمج، تشوف الليمف نود يعني lightening زي ما انت وريت في الصورة. احنا ما قاعدين نستعمل. انا I don't know any hospital using it here. Maybe Muna does know.
Okay.
لكن the
Cambridge. Only Cambridge they use ICG.
Cambridge. يعني الحكاية هنا احنا as long as احنا we are doing dual technique وبالcost و very good specificity with sensitivity، فما صعب انك تعمل business case في الهوسبيتال to buy all this stuff. لكن it's a good way. وهسه كمان مع الماك سيد والماك تريس الموضوع زي ما منى described بقت حاجة يعني هم trying to push it more than anything else, and the detection بتاعها very good and you can use it at later stage and you can inject 1 month before your surgery ولسه بيكون في الماك تريس قاعد. بس حاجة بالنسبة للأذنة كانت very promising. يعني طبعا الأذنة when it came كان زي ما أنت قلتها we thought إنها حتكون الفيوتشر بتاع الديتكشن بتاع الليف نود، لكن because of the evolution في الاكسيلري تريتمنت وبقى في دي اسكليشن، الاذن بقت شويه كده ما ماشيه مع الدي اسكليشن، لانه في النهايه انت الاذن ما بتوريك اذا كان ده مايكرو ميتاستاسيس ولا ماكرو فيرست اوف اول، يعني ديتكت جاست الدي ان اي يعني يو نو اتس بوزيتيف. والسكند وانت ما بكون في اي باقي من الليف نود، يعني انت you use all the lymph nodes for the OSNA to detect the DNA وما بكون في remaining tissue to check if it's macro ولا micro metastasis. والناس زي ما قال الدكتور رباب انه اليوزج بتاع الأذن كان to detect it and to go ahead with clearance، لانه بقى ناس بعد ده بقى في الترايلز اللي قلتها دي ستارتنج من الامورس ترايل ان الناس يدوا راديو ثيرابي لللو فوليوم، بقت الاذن شويه رجعت لورا. maybe they will be a use for it in the future in a different way لانها very good technology, so it might be the future but in a different way of what we used to use it.
Good comment.
Good afternoon, everybody. Thank you, Dr. Omar, for
how are you?
Thank you, Dr. Omar, for very comprehensive and detailed lecture about axillary dissection and the future of axillary dissection and these things. Thank you so much. I do have two comments. I attended conference in Aga Khan in Kenya, and there was invention of doing sentinel lymph node with injection of iron. And during the surgery, all the instruments is plastic, and they used a magnet to find if the axillary lymph node is involved. I don't know if you have an idea about this. The second thing, I think we have to follow every new invention and every new techniques, but we have to come back to the ground of what is available in our country. Even before the war, we have only one or two centers of radiotherapy. So I think we have to sit down and to put our own guidelines on management of our patients. And we have to study or to have studies about the biology of the cancer in Sudan, and to put our local guidelines according to our facilities and according to the biology of the disease in our country. Thank you.
Thank you very much, Aida, for your comment. Yeah, we always say that we have limited facilities, but one thing we learn about from this war is that if you ask, people will give you. Yani, during this war, a lot of initiative from our colleagues abroad and the organization. If you just tell them what you want, you will get it. So I hope that this lesson will help us in the future to approach the organization and the international community in the right way. I think in Sudan before, we don't know how to approach these people. They have a protocol to approach them. If you approach them right, they will give you. And the community of our doctors, the expert, they really helped now during the war and actually before the war. So buying this new instrument, I don't think will be an issue if we direct them to 1 or 2 centers of excellence in dealing with breast cancer. شكرا عايدة على your comments and thank you very much.
Comment برضو to add to Mr. Omar's talk. Ms. Aida, I think what you are talking about is the MAC trace. لأنه الماك تريس هو الانجكشن عبارة عن ion nanoparticles. Yeah, you inject them same like the dye, the methylene blue or any dye. وبعدين you use a magnetic probe to detect them. يعني بيديك sound لما تجي عليها في الأكزيلا. هو ده لأنه ناس الماك تريس هم نفسهم ناس الماك سيد، يعني اللي وراها مستر عمر في البرزنتيشن. الماك سيد برضه magnetic particle. They put it to mark the cancer instead of wires والحاجات دي. And you use the same detector, the magnetic detector to detect the cancer. فهم عاملين الماك سيد والماك تريس to check the lymph node by injecting an ion nanoparticles. عنده downside طبعا. واحدة منها إنه هو عنده براون pigment بتقعد زمن طويل. والحاجة الثانية لأنه هم النانو بارتكلز ديل بيكونوا قاعدين في السكين لزمن، فبيأثروا على الام ار اي. يعني لو جيت تعمل البيشنت مثلا عنده ريكارنس ولا حاجة ده تعمل له ام ار اي في البريست، فبي بيكون يوزلس الام ار اي في الحالة دي. عندها بوزيتيف ونيجاتيف. وعندهم ترايل لحاجة اسمها ماك توتال أعتقد، اللي هم انجكتنج الماك تريس دي أندر الكانسر، بحيث إنك أنت to use it to detect الكانسر وبرضه to avoid السكين pigmentation والحاجات دي. برضه الفائدة بتاعتها إنه you can inject it ahead of the surgery like 1 month before surgery. والحاجة الثانية زي ما برضه منى قالت إنه لو أنت هتعمل ماستكتومي في DCIS and I hope ده غالبا دكتور رباط presentation هيكون فيه الحتة دي. ف instead of doing a sentinel node biopsy you can do a mastectomy لأنه already الماك تريس مشى للليف نود، ولو طلع فيه invasive components you can come back للليف نودز after that.
والأذر بنفيت برضه تقاد غسان للماك تريس اللي هو السبيو دي. يعني ما في radioactive activity. We don't need nuclear medicine department. We haven't got nuclear medicine department. We know the side effects of blue beta dye. So if we got the wish to change, I think we can after this war is stopped. As Mr. Omar said, all people abroad, they are quite keen, quite happy for the practice to improve for our patient to get a best care. But if we put our hand together, all of us as multidisciplinary team, we can change the things. But let us stop the war first. We did start already before the war. I think everyone remembers that we came to Khartoum Center and we have done a brilliant workshop, and we were hoping for this to continue. But let us hope now the war is stopped, and then, yeah, if we got the wish, I think the things will happen.
Yes, as you said, Dr. Mona, is Mrs. Mona, the most important point of using the nano ion labeled is to avoid the radiotherapy or the radio exposure. Yes, the radio exposure for the staff and for the patient. This is a benefit. I hope they can improve it to take the effect, the long effect, and the pigmentation of the lymph node. I hope, we hope the war stops and the benefits for the whole Sudan, not in one center, in all Sudan. Thank you so much.
All right, thank you. This is really great discussion. Thank you, Mr. Omar, for the great presentation. Now we move on to the next speaker. I'll introduce him, Mr. Muawiyah Deborah. He's Associate Professor of Surgery on the Rabat University. He's also plastic surgeon and breast surgeon practicing at the moment in the, I'm not sure, in Saudi Arabia. But before that, he has been practicing and doing a great job really back home in Sudan in the area of Bahri. He really has transformed the surgical practice there and has been part of his team, being fortunate enough to work with him at that stage and that era. So he is a member of the American Society of Breast Surgeons with a fellowship in breast surgery in Taiwan. So for the next few minutes, he will be discussing with us the role of chemotherapy in neoadjuvant treatment in downstaging and shrinking the tumor. And also we'll have a special emphasis on the keynote trial and the importance of that new modalities in improving the outcomes surgically and oncologically in early breast cancer. So thank you, Mr. Mawia.
Thanks, Ms. Tamadur. Thanks all. Just preparing my is my screen clear to you?
Not yet. No, we cannot see it yet.
Not yet?
No.
I think we can see your screen, but you are not sharing the presentation, your presentation.
ايوه.
Yes.
Now you are
can see it
seeing?
now. Exactly, you can see it now.
Okay. Objective of my talk is overview of neoadjuvant therapy and oncoplastic surgery, goals of neoadjuvant therapy, challenge of oncoplastic surgery after neoadjuvant therapy, efficacy of oncoplastic surgery after neoadjuvant.
معاوية ممكن تكبر العناية؟